All right, guys, this is going to be chapter 3, medical, legal, and ethical. I will warn you, this first module, up until we start getting to like the human body, it's a lot of dry content. It's not very fun, interesting, cool stuff, but this is stuff you absolutely need to know. All right, these definitions, all of this intro is laying the foundation to set you up for a successful healthcare career, especially this stuff. It's not very fun to learn about, but you've got to know this stuff to avoid lawsuits, to avoid, anything that is not going to bode well in your practice as a patient care provider. Okay, so bear with me. I know it's dry stuff. If you want to get up, walk around, move around, get the blood flowing, I'm good with that. But just we got to power through this stuff. Okay, so we'll get to the fun stuff later, I promise. All right, so basic principle for healthcare in general is what? Do no further harm, right? Whatever we're diagnosing our patient, however we're treating, whatever we're doing for interventions for our patient, we have to have in good faith and good interest of that patient, that mindset that we're doing this because we want a good outcome. We don't want to cause any further harm. Okay, you've got to keep that in the back of your mind. You've got to act in good faith that you're positively wanting a good outcome for this patient. Okay. So again, it doesn't matter. So when we were talking about the Good Samaritan, right? If you don't know any better, you're covered from a lawsuit, right? But once you know how to do CPR correctly, you got to do it correctly so you avoid any type of legal action. Now, like we said earlier, in the process of doing CPR, guys, it's very invasive. You will break ribs if you do it correctly, okay? Guaranteed almost every single time. We can cause injuries from doing it the correct way, right? But if we're doing it the correct way, if we can prove that we are acting in good faith of that patient, we were doing what we did because we wanted that patient to have a good outcome. We wanted that patient to survive. There's no way that anyone can prove that we were doing that towards the patient to intentionally cause harm. That's how we avoid lawsuits, okay? Because there are a bunch of different loopholes that we're kind of exempt from, or that our legal teams can get us through when it comes to legality. Because if you document correctly and you're not acting a fool on scene where somebody's videotaping you saying, cussing the patient out or doing anything questionable that can lead to eventually saying, well, you said this or you did this, who's to say you didn't want that patient outcome to be negative? Right? We got to act in good faith with the patient, and we got to document our bottoms off, and then we're usually exempt from lawsuits. Okay?
Has anyone ever tried to sue, like, for just regular CPR injuries?
Oh yeah, guys, probably on a daily basis. Our legal team goes through these cases and has to sort through them and say, okay, like they either don't have ground, let's get this dismissed, or let's see what we can do to try to make this go away. Yeah, I've been through a couple of them myself, and we'll talk about that in a minute. All right. Okay, we're gonna start off with a banger. Consent. What is consent? What's the definition of consent across the board for anything?
I'm saying yes.
Permission to do something, right? So it is very, very important that you understand the definition of consent and understand there are different aspects of consent when it comes to being a healthcare provider. Okay, so first and foremost, we've got to have a patient who says, yes, I called you here. Yes, please come take my vital signs. Yes, please take me to the hospital. Because if we just show up and we just automatically go assess that patient and they're not giving any indication that they want our help, we run into some problems, okay? So make sure in some way, shape, or form we are getting permission from these patients to perform patient care, to do interventions, to do even an assessment, guys, physically putting your hands on them. We've got to get permission first, all right? So we will talk about who is eligible for consent. right? What has to be in place for a patient to make a sound decision for themselves?
Okay.
Right, they got to be conscious, right? They got to be able to have a conversation with you. What else? They have to be in their right state of mind or a sound state of mind. All right, what does that mean? Okay, they can't be drunker than Cooter Brown
Mental disorders.
on drugs because that's going to impair your cognitive ability, right, to some aspects. What else?
Mental disorders.
Okay, so maybe like a mental or a developmental disorder that does not allow the patient to physically have the capability to make a decision for themselves, right? So yeah, if we've got a patient like we talked about, there's several different reasons a patient can be acting a little altered, right? Their oxygen levels, their sugar levels can be low. They can have a brain injury. They can have pressure on their brain that's causing them to act erratically. We got to make sure all of that is kind of eliminated and understand if a patient actually can consent or, you know, refuse on the other side of that point. Okay. We'll get there in a second. All right, what are some things, what are some conversations, some ways that we can try to determine if a patient is in their right state of mind?
You know what day it is?
Okay, so we're gonna ask some questions. Right? All right, guys, I don't know if y'all can see this whiteboard beautifully, but I'm about to write on it. All right, we want to make sure a patient is alert and oriented times 4. Not 3, 4. All right, so if you hear the term patient is A&O times 4, that's going to be kind of the abbreviated, they're alert and oriented times 4, okay? So we've got A, alert, and O times 4. What do you think those 4 things are?
4 questions.
So kind of 4 categories that they can give me an appropriate response on, all right? What are those 4 categories?
Name, date.
The location where they
All right, so for those of you who can't see the whiteboard, it's going to be person, place, time, and event. All right, those are the 4 different categories that we're going to gauge my questions I'm asking my patient and their responses to see if they are actually cognitively able to make a decision for themselves. If they are in that right state of mind to make a decision whether or not they can give consent or they can, you know, be transported. All right, what's the person? What am I going to do here? How am I going to ask this question?
Tell me your name, when were you born?
Yeah. Hey, sir, what's your name? Hey, ma'am, can you tell me your name? All right, so unless they have like an ID on them and they give us some elaborate name, we can't really confirm or deny if they're, you know, telling us the truth, right? All right. What is place? Where are we? All right, guys, you got to be careful about this because keep in mind, these questions are not designed to trick our patient, right? There might be some patients who, we have a big homeless population, all right? Especially when it comes to time, it might be a little altered for them. So we'll get there. What about place? Where are we? What are some different ways to ask that? What city are we in? Okay, what else? Okay, if we have a very recognized, where are we right now? Are we in the classroom? Are we at a football stadium? Are we on the side of the road? Are we in your living room? Okay, we're asking questions. We can kind of elaborate, kind of tell just to make sure that they're aware of their surroundings. Right? If I'm a person and I'm just gonna, or you know, transient or whatever you would like to call them, and I'm just traveling in and out, I might not exactly know what city I'm in, right? If I'm within my state of mind, I can tell you I'm sitting in a classroom right now, or I can tell you I'm sitting on the road, right? As long as they're aware of their immediate surroundings, then I'm okay with that. Okay? What about time?
Got a little bit of echo going on in
Has anybody got their mic on? There we go. All right, so what about time? What can I ask about time? So maybe day or night, but what do we run into with both of those things?
If there's a visual issue.
We
Maybe
can
if
ask if they know what year it is.
you're outside, but if you're outside, it can be daytime, but it's still dark, right? It can be nighttime. If it's in the summer, it can be 9 o'clock at night and it's still light, right? So again, we're trying not to confuse or trick our patients. What else can we ask?
You know
What year is it?
Okay, so let's go with the day. Why might that pose a problem? Because guys, if you ask me what day it is, I'm gonna have to look at my watch to tell you, right? I lose track of what day it is, especially with the whole like quarantine thing. You're like, what year is it? All right, but yeah, so what if we have a homeless patient who doesn't have a daily routine? They don't know that it's a Tuesday, so they have to get up and go to work, or it's a Wednesday, they have to get up and go to class. All right, they're just kind of coasting from day to day. They might not be aware of what day it is. Doesn't mean that they're altered. Okay, so maybe we can do a broad, if they're confused on what day it is, well, okay, well, what month is it? Do we know what month it is? Okay, they still might be kind of oblivious to that. We can try for a year. What year is it? I don't know why, but patients, a lot of times when you ask this question, they will tell you the year they were born, and they think that's the question you're asking. So if they say, oh, it's 1948, no, not the year you're born. What year is it right now? Okay, who else might have a problem if we're asking them what day of the week it is? Maybe
senior,
so we're definitely going to get to that whole category. But who else?
seniors,
Who?
seniors, the elderly.
So maybe kids. Yeah, definitely kids. That's a whole nother ballgame, right? But somebody who doesn't really get out and do much. Somebody maybe who is either bedbound or stays in their house. They don't get out and really go in the outside world. They might be only able to keep track of what day it is because of what program's on each day, right? So again, we're not designing to trick our patients. We just want to have these questions applicable to their lifestyle, what's going on with them, okay? What about event? Why am I here? What happens? Why did you call 911? How can I help you? You know, did you fall? Do you remember everything that happened? And if they're like, oh, well, I don't know. Well, what's the last thing you remember? All right, that's going to tell me if at any point they actually lost consciousness with their brain and it kind of like shut down for a minute. Okay. So what if I have a patient, I come on scene, I ask them all of these questions. Guys, you also might hear a couple of common knowledge questions thrown out there as well. Because if some of these answers are a little questionable, we might throw in something else. What might you hear? Okay, so maybe something simple, what's 2 plus 2? Or maybe how many quarters are in a dollar? That's a really common one. What else?
Who's the president?
Who's the president? Not who would you like to be president, but who is currently president, right? So just general knowledge questions. All right, what if I come on scene and I'm talking to my patient and they are answering every single question appropriately? And they say, no, I was freaking out earlier. I called you guys, but I don't want to go to the hospital anymore. How do I handle that situation? Is my patient in their sound mind? Are they answering these questions correctly? Yeah.
You just said yes, yeah.
They don't understand the implications possible.
Okay. So we'll get there. Guys, as long as my patient is A&O times 4, they're not under the influence of drugs or alcohol, if they're not a minor, we'll get to that. If there's not any kind of language barrier where I cannot 100% establish that they are aware of the repercussions of the decision that they're making, if they tell me they don't want to go to the hospital, do they have that right to refuse treatment and transport?
They definitely have the right of refusal.
Yes. if they're within their sound mind and there's not any other stipulations like they're a minor, or if somebody has power of attorney over that person, which means they make the legal decisions for that person, or if there's some other circumstances we'll talk about a little bit later, they absolutely have the right to refuse.
Isn't there a form that you would sign?
Yes.
They would have to sign.
Yes, yes, guys, throughout this entire chapter, I'm going to go back and talk about your documentation. It is so, so important that you document thoroughly and with as much detail and as factually as you can. Because my anal retentive documenting skills have gotten me out of going to court. Okay, so make sure, I'm telling you this from personal experience, I'm a stickler when it comes to documentation because it will save your bottom. All right, so yes, if I did a thorough assessment, because technically, can the patient refuse me doing an assessment on them?
Yes.
Okay, if we come on scene, I didn't call you, my neighbor called, I'm fine, I don't need any help, I don't know what's wrong with them, I was just, singing and they thought I was yelling because I was hurt. I don't know. All right, I don't want you to touch me, I'm good, y'all go on. If I ask those questions and make sure they're within their sound mind, they're not drunk off their you-know-what, or they're not under the influence, all right, dude, we're good. Please sign here, saying that we came out, we offered to assess you, and that we offer the option to take you to the hospital, but you refused on your own accord, we're good to go. And sometimes you refuse to sign.
But what is
Is that also
Hold on.
is that also what you do whenever somebody has a visible injury that probably should be treated like a stab wound or something like that, and they're still of ANO times 4 and still refusing treatment?
We'll get to that in a minute because that's a whole different level of a refusal. But yes, we'll get to that.
Yeah, like what if they refuse the A&O?
So guys, if they are conscious enough to walk away on their own accord, they're not stumbling, they're not falling over, they're not talking to you, you can write that up as, patient was uncooperative, didn't notice any obvious, life threats type thing, patient walked away. That's fine. But you got to be able to justify that you did everything within your power to determine if they were ANO times 4 and make sure that they didn't want treatment/transport. All right, so if your patient is within their sound mind and they don't have any other kind of considerations of their mental or their decision-making capability, they absolutely have the right to refuse you doing an assessment or for transport. They might be totally okay with you taking their vital signs and doing an assessment. They're like, yeah, sure, you can check me out, but I don't want to go to the hospital. I don't want you to take me to the hospital. Okay, that's fine too. All right, sign here. There's a particular form, depending on what software your company uses, that you'll click the refusal and you will say, hey, I want you to understand that you can always call me back. Doesn't mean that if you don't want it to be transported now, you can't call 911 back. But you are aware that, you're refusing to be transported right now, and, up into including death could happen to you if I walk away and don't treat you. Okay, that's just kind of a blanket statement that we put out there.
In addition to your level of documentation, do you ever wear a body cam?
We don't, no. APD does, yes. But no, EMS doesn't because of privacy laws.
Yeah.
What if you do an assessment and you find something that's still the one?
I'll get
Like
there.
it's an
I'll get there.
What is the O stand for?
Oriented. So they're alert, that means that their eyes are open, that they are aware that you're in proximity, and they're oriented, they're able to respond appropriately when you ask those questions.
Sorry, someone in the classroom asked something and you responded that the police do, but we don't. I couldn't hear that question.
Body cams. We don't wear any kind of body cams to record the interactions because of privacy laws, but you might have an APD officer on scene who is wearing a body cam. If something were to become like a lawsuit or something, they would definitely track down that PD's body cam and use that as evidence for justifying your refusal / whatever. Okay, so everybody's clear. what consent means, the overall blanket statement of consent, right? How we determine if a patient is eligible to either consent or refuse, right? We have to make sure they're alert and oriented times 4. And if they are alert and oriented times 4, we understand that they absolutely have that right to say, no, don't assess me, no, don't treat me, no, don't transport me. Everybody's on the same page so far? Okay, all right. All right, so there are different ways we can have that consent given to us, right? Expressed consent is going to be either verbally or non-verbally by the patients, indicating, yes, you can do your job. So if you say, hey, ma'am, my name is Kayla, do you mind if I check you out? Can I get your vital signs? I need to check your blood pressure. My patient can look me dead in the eye and not say a word, but if they do this, if they extend their arm out to say, yes, here, use my arm to take my blood pressure, that's considered nonverbal consent. They're expressing non-verbally that they are okay with me assessing them, getting their blood pressure. Okay, guys, usually we walk up to these patients, the first kind of interactions, hey ma'am, I'm Kayla, I'm from Grady, what's going on today? How can I help you? Okay, so that way we can gauge a lot of information based on their response. And if they're like, oh, this is going on, then we just kind of move in and just say, okay, are you good with me getting some vital signs? Or, hey, let's check your vital signs, let's do this to make sure you're okay. And then if they have a problem with it, they'll say, no, no, no. But if they're like, yeah, sure, do your thing, then that's also express consent verbally.
You don't have to do that with everybody.
No, you don't technically have to go to every single patient. Do you mind if I get some vital signs, or do I have permission? You can if you want to. It'll cover your rear ends tremendously. But typically they're just a normal conversation. Hey, how's it going? Well, let's check you out. Let's make sure everything's okay. Then we'll gauge whether or not they're going to give consent or not.
That's what I was gonna ask about the A&L 10-4. If you really ask that every single time.
Yeah, so the question was, you don't have to go up to every single patient and say, okay, first and foremost, what's your name? Where are you? What's going on? We don't have to ask all of those questions. Guys, if you're having a normal conversation with your patient, you'll be able to tell, are they interacting with you appropriately? All right, if you go up to somebody and they're holding a conversation with no type of, slurred speech or weird responses, they're just holding a normal conversation, I'm probably not gonna question their mental capacity. Right, but if my patient's just standing there, just staring at me, looking at me, or like zoning off, or just acting inappropriately, then I can be like, okay, well, hey, based on your reaction, let me ask you a few questions. Okay, and then we can go from there. All right, everybody good? That's expressed is either verbal or nonverbal, and they are saying, yes, take me to the hospital, or just simply body language, do your thing. Okay,
Take this as dating advice.
question?
No, I just made a lame joke or something.
All right, so now we're gonna jump into these different branches of consent when it comes to healthcare. All right, what is implied consent?
They're not responsive.
They are not responsive.
What you just described.
They are not able to say, hey, I'm hurt. Hey, I just got hit by a car. Hey, I just got shot. I'm lying here dying. Can you please help me? All right, this is gonna fall for those patients who are unconscious, unresponsive, and it is just assumed that if this patient were conscious, if they were able to interact with us, they would say, yes, please, put a tourniquet on my arm, stop me from bleeding out, and save my life. Unless they have something like a suicide note on them that is saying, oh my gosh, please let me die, I did this to myself, guys, even then, they fall under implied consent, right? Because I think it is safe to say that everyone in this room, if you got hit by a car and you weren't able to either verbally or non-verbally say, yes, please save my life, that it's just assumed that you would give that response if you could, right? So these are going to be for patients who are unconscious, unresponsive. We cannot talk to them, but it's just implied. It's assumed that they would want us to treat and transport them.
Miss A?
Yes.
I've seen someone with a do not resuscitate tattoo on their body, do tattoos count or do they have to have the legal paperwork? It doesn't count?
Tattoos don't count.
Awesome, cool. I wanted to clear that up. But can they have legal do not resuscitate paperwork? Is that a thing in Georgia or no?
That they can have.
Okay.
But if it just says do not, if they don't have the documentation, it's just like it doesn't exist. I'm going to work it under implied consent.
Okay.
They
thank you.
tattoo the legal document to their body.
I'm sorry.
Can they tattoo the legal paperwork to their body?
Technically, they can. Yes, they can, and we're actually going to talk about that either this chapter or next. But we'll get there. We'll get there.
What was the question?
Can they tattoo like a photocopy of a legal document on their body? It's a thing. All right, guys. So when it comes to this, don't be a jerk and just go up to your patient. Let's say it's like a homeless patient and they're just literally taking a nap on the sidewalk. They're not drunk. They're not injured. They're not altered in any way, shape, or form. And you're like, hey, sir, can you hear me? And if they're asleep, they don't respond to you. Oh, it's implied consent. Let's throw them in the back of the truck. Let's take them to the hospital. That's not really the way implied consent works, right? So just make sure your patient truly is unconscious, unresponsive, or otherwise incapable of making an informed decision about their health. Okay, so that could be a patient who is maybe a minor and significantly injured, or it could be a patient who has a developmental disorder and is critically ill and we need to transport them and they're not able to voice cognitively a decision for themselves, okay? Again, don't use implied consent unless it is life over limb. What does that mean?
Life over?
So we use life over limb for implied consent.
You'd rather save their life.
Yeah, if they're truly going to be in a life-threatening situation, that's when we're going to have implied consent, kind of fall into play. Not if they stub their toe on a coffee table or something like that, and then I don't know what a stipulation would be that we would not use implied consent, but they've got to be unconscious, unresponsive, or significantly injured and unable to communicate that decision, okay? You can also, implied consent will fall regardless, you'll be covered by it, but if there's a friend or a family member on scene, be like, hey, I know I can't talk to your husband, but he's really sick, we need to take him to the hospital, are you okay with that? I mean, again, unless they poisoned him from a Dateline episode, who's going to say, oh no, we weren't really getting along anyway, you can just let him die? No, everybody's going to be like, yes, do everything you can, save him type thing. So that can also be another supportive piece of information you put in your chart, right? Implied consent, you're covered, but you can also say patient wife, stated desire to transport/treat or whatever. All right, everybody good with implied consent? Okay, who falls under that implied consent when we can kind of get away with transporting even without them saying, yes, please take me? All right, now we're gonna move into involuntary consent. This is where the two worlds kind of collide, okay? This is gonna be a subjective sometimes, and sometimes this is not fun to carry out, all right? Mentally ill, maybe behavioral crisis, or maybe developmentally delayed, maybe a minor, okay? I can come on scene, and let's say I have a 35-year-old man who lives alone at his apartment, has no cognitive disabilities, and I get a call, a friend calls 911 of this patient and says, hey, my friend just texted me this, said that they're gonna go kill themselves, they're gonna go harm themselves. I need you guys to go check up on them. We get there, my patient's ANO times 4. Totally responsive, totally appropriate to the questions I'm asking them. But if I can gauge, if I can get some type of, not so much proof, but if I have any type of indication from my patient's responses or any texts I might see or anything like that, that indicates that they want to harm themselves or harm anybody else, we're in a different ballgame here, okay? We like to refer to those terms as the patient has suicidal ideations. The patient is positive for SI. You'll hear that term a lot, SI, suicidal ideation. Or they're positive for HI. What is that? Homicidal ideations. And guys, we usually use these terms when we're giving a report, so we're not just like sitting right next to the patient and be like, yeah, they're suicidal, yeah, they want to kill themselves. That's kind of awkward a little bit, right? So if I can prove, or if I can gauge that they are suicidal or homicidal, it does not matter if they are ANO times 4. All right, if they have an IQ of whatever a high IQ is, if I can prove that they are going to harm themselves or they're going to harm somebody else, they have to be transported. Why?
Because if they go and do those things, you're liable also. Like, they can't, if they're mentally ill like that, they can't like be helped. They can't know. I know what I'm trying to say, but like they won't want treatment because they want to do those things, even though they're like bad if you're in the right state, like mine.
Okay.
Yes.
They're compromised.
Yeah, so guys, it's a liability, right? Because why can't I just say, oh, okay, I mean, that sucks that you're that unhappy. You know, go follow through with your plan. Maybe you'll be happier on the other side.
They're 100%.
I'm not acting in good faith of that patient, right? Because if I just say, oh, cool, I know we got a text saying that you're going to kill yourself. I mean, you know, whatever, I don't care if you do, go ahead and do it, and we leave. And they carry out that plan and they end up dead. Who was the last trained medical professional to come in contact with that patient? You. If you did not insist and act in good faith of that patient's life status, that they be transported and evaluated and monitored, you did not do your part. All right, your neglect of action led to the death of that patient. Okay, so same thing if they're homicidal. If they've sent out, like if they put a Facebook post that they're gonna go shoot up a school or go shoot up their workplace or something, and we get called, and we can, you know, we see the proof in front of us, or the patient says, yeah, dude, F them, I'm gonna go, you know, take care of them. Time out. They might be ANO times 4 technically, but if they have intent to harm other people, and we're like, well, you're ANO times 4, you can't refuse, have fun, and they go out, we can be charged with X amount of cases of death because we didn't do our job.
How do you do that?
Professor A, I have a question.
How do you do that without compromising yourself?
Okay, okay.
I'm saying, would the police get involved?
Yes.
Okay, so let's just say we're in a situation where we do recognize that a patient is compromised because of either of those two reasons. I know how we would handle it in the event of us recognizing it's a homicidal situation, but what if it is a situation where it's a suicidal situation?
Okay, so the collective question was, well, how do we handle that, right?
Right.
Guys, it's going to be a case-by-case thing because what's our number one concern?
Our state.
Our
The well-being of, yeah.
my scene safety, okay? Because guys, if you've got, I can't imagine being in a spot, in a place in my brain that I would want to take my own life, okay? So with the people who are in that mentality, a lot of times that's why we see a lot of murder-suicides, right? I'll take myself out and I'll take somebody else out with me. So if they're in that dark of a place, who's to say they're not going to say, well, screw it, I'm going to be dead anyway, I'll kill you if you get in my way, type thing, okay? So we have to handle these situations very carefully because they can progress to being violent, right? Our scene safety can be compromised. Guys, again, you get what you give. If you gather that we're in a spot where we're going to have to involuntarily transport this patient, if you come out guns blazing and be like, well, guess what? I don't care if you want to go, it's my way or the highway, you're going anyway. How are you going to be met with that? With aggression, right? They're going to fight you tooth and nail about that. Again, guys, there's not a script for this type of thing, but the best way that I have found to phrase this, because we don't want them to view us as who?
An enemy.
The bad guy, right? The enemy. All right. We want them to let them know, hey, I'm not trying to be the bad guy here. I'm just trying to do my job, right? So the best way that I found is, look, this sucks. Okay. I'm really sorry. I know you don't want to go, and I don't like making anybody do anything that they don't want to. But because you have said X, because you have sent out X, it's my job. I cannot legally leave you here by yourself. All right, so if you kind of put that out there, hey man, I'm not doing this because I get a kick out of, you know, pretty much kidnapping people. This sucks. I'm really, really sorry, but ultimately you have to go. There's not an option here. Then they're more likely to cooperate with you because they're perceiving that you're not forcing them just because you're being a jerk. Okay, so if we put that out there and they're still not being cooperative, then we need to start thinking about escalating it to maybe we need to get PD involved. Guys, again, we're always going to try to de-escalate first, right? Try to talk to your patient, try to approach it with a calm manner. But we do get to the point where we can physically restrain these patients. And if you have ALS involved, you can chemically restrain the patients. Guys, that needs to be your last resort. That needs to be the last thing in your mind when you're getting these patients to cooperate with you to be transported, okay? We'll get there in a little bit, but let them know that you're on their side. And if it progresses, if they're still not cooperating, we will get PD involved. We will get supervision involved. We will get some paramedic drugs involved to get them transported.
So like if you got a citation, what?
Haldol and Versed. All right, so guys, that's going to go for the suicidal or the homicidal patients. Mentally ill, developmentally delayed. Again, they might not exactly be ANO ×4, which makes them altered in our book, right? They might not be able to understand what's going on with them. They might not be able to understand what happened to them, where they are. So technically, guys, if the patient is altered in any capacity, then they typically fall under that involuntary consent, okay? They might be altered, but they might understand, I don't want to go to the hospital. If we're having a psychiatric emergency, if we have a cognitive delay, and they can't make that sound decision for themselves, they're going to fall under involuntary consent. We cannot leave them there by themselves. They have to go. Okay?
Dr. A.
So maybe like a psychiatric emergency where they might be like bipolar schizophrenia, they might be, you know, whatever, and they're having an erratic moment and they're acting erratically. They might be having that moment, but they still might be able to tell you where they are and who they are. But because it would be a liability if I left them by themselves because I can't predict what they're going to do, they're going to fall under involuntary consent. Question?
Can you just turn the laptop to the screen so we can see the whole thing, please? Thank you.
Sorry. Yes.
When you're in that situation, right? I don't know, I'm playing this out in my head. And I'm thinking about all the different union situations I've been in over the years, some that have turned hostile, most. How do you do that? How do you continue to do that without that person escalating? I mean, they might become compliant and then totally change their tactic when they get in it. How do you call PD? I mean, certainly I wouldn't leave you standing there with that person, right?
Right, so guys, that if it's starting to evolve to the point where we respond, it's just us on scene, and then we're perceiving, all right, this patient's not going to cooperate, we need PD to come en route. Before PD gets there, if that patient turns aggressive, that's not my patient anymore, because what's been compromised? Mine's in safety.
But how do you contact them, right? I mean,
over the radio. You'll get in touch with dispatch and say, hey, dispatch, we've got X going on here at my scene. Can you please get PD en route? And you can let them know, hey, you need them here right now, or, you know, they can take their time getting here.
And that person doesn't really do it at
all? Sometimes they do. Sometimes we like to be a little discreet over the radio. Again, we use SI and HI. We can use, you know, just terms like uncooperative or combative or something like that. And we're not going to say, hey, they're, you know, being a douchebag over the radio. But tactfully and professionally, we'll let them know we need you back up here.
They don't just come, like, there's no way that they can know if it's like a mentally ill patient. They can just send both of you together.
So technically, the way that it gets triaged, if it comes out as any type of violent, like a domestic, a shooting, a stabbing, anything like that, if it comes out as a psychiatric involvement, technically PD is supposed to go ahead and co-respond. Things are different with COVID. They're choosing not to respond to some calls unless they are needed. Same thing with fire right now. They're not responding to hardly any medical calls unless we call for backup, and then sometimes then they don't pick up. So again, that little excerpt I read to you guys, expect no help. It's real right now with everything that's going on. So yeah. All right, so also involuntary consent, who falls underneath this? Minors, right? Kids. You are not an adult until you turn what? 18. All right, so be mindful of that. All right, moving into minors and consents. Because guys, can you come on scene to a 15-year-old who is A&O times 4 and says, dude, really, I've got a stomach ache. My mom is just a hypochondriac. I don't want to go to the hospital. Everything's fine. It's fine. I don't want to go to the hospital. It doesn't matter. If mom is saying, nope, no, he's going to the hospital. He has appendicitis. I'm sure of it. WebMD told me that he needs surgery. He's going to the hospital. Who am I listening to? Mom. And again, it sucks, right? Because I got to tell that 15-year-old, I'm pretty much doing what to that 15-year-old? Kidnapping him, right? Hey, dude, I'm sorry. I know this sucks, just like our SI and HR patients. I know you don't want to go, but your mom's saying that you need to go, and she makes your decision. I'm sorry. I don't want to take you if you don't want to go, but we got to go. Let them know that you're not the bad guy, because sometimes they can get aggressive as well. All right, so now there are a couple of loopholes when it comes to this. If you are a minor and you are what? You can make your own decision. Emancipated, what does that mean? You're legally free from the ties that bind you to your parents or your guardian, okay? There's a couple of different examples. If you are legally married and you're a minor, you can make your own choices.
What about like if the minor wants to go but the parent won't let them?
That's something we'll reevaluate to see if it could possibly be like neglect or something like that. Yeah, we'll get there. All right, if you are in the armed services and you are under the age of 18, if you're a minor, you are emancipated. Okay, if you have gone through some type of legal battle, you've gotten a judge to say, hey, your home life is so terrible, your parents abuse you, whatever it is, and you have documents that say that you are legally emancipated from your guardian or your parents, you can make your own decision. All right. Where is the one that gets really, really complicated? If they're pregnant. All right. So if you are a minor and you are pregnant, you are temporarily emancipated to make your own medical decisions. Why? Okay, so you're in charge of another human being. Huh?
Is it Roe v. Wade?
I don't know exactly, so I'm not going to say yes or no. So you're in charge of another human. What are you doing with that human?
Like you're
You're growing it. Where's the human at? In your body. All right, so that minor, whether they're 12 or 17 and 360 days, they have a human inside of them. We will talk about it when we get to the OB chapter. Anything that is in mom's system is also in whose system? Baby's. Good stuff and bad stuff, right? If the mom, the mother of that, the minor mother who is pregnant, doesn't want any medical treatment or any pain medicine because it'll affect the baby, that's her choice. That baby's in her, right? So they are temporarily emancipated to make their own decisions while they're pregnant because their treatment can affect the baby. Here's the kicker. Once that baby is born and is not solely dependent on that minor mother, that 16-year-old who just birthed that baby goes back to being a minor.
Right.
Her parents make decisions for her.
She makes them for her child.
Well, who makes the
Makes the healthcare decisions for the child.
who
Right.
makes the decision for the baby?
Sorry?
Who makes the decisions for the baby?
The minor mother who just birthed the baby.
So she can make decisions for a baby.
Even when she goes back to being a minor?
We're another human being, but she can't make decisions for herself.
So for 9 months, she'd be applicated. And then after that time,
For the duration of the pregnancy, and there's a little bit of a postpartum stage where, like, if baby's breastfeeding or something like that. But yeah, she's temporarily emancipated while she's pregnant. But after she births the baby, she goes back to being a minor in the eyes of consent, but she can make decisions for her own child.
Can the minor mother's parents make decisions for the baby?
Okay, so no. So she's pretty much said, can the grandmother make the healthcare decisions for the baby that was just born? No. Unless, guys, there is an issue, there is that the grandparents have legal guardianship over the newly born baby, then yes, they can. But it's going to be the mother of that child who was just born, that 16-year-old who makes the choices for the baby. Okay? Weird, crazy, I know. But it is what it is.
what about children that just don't have anybody around? Like if you get a call and you just find a kid.
So if you get a call and you just find a kid like on the side of the road, right? Even if they're 15 and they're telling you, hey, I'm fine, I don't want to go. If they are injured, if they do need to be transported, we need to take them. They'll fall under involuntary consent. All right, guys, so staying here, if you get responded to like an elementary school or even up to a high school, if you've got a minor and they're having a medical emergency, then if they can't get a hold of the parent, the teachers and the school can't get a hold of the parent, the teachers and the school can make decisions for that patient. They have kind of temporary custody of that patient. They'll ride into the hospital with you until a parent can meet up with that minor, okay? So again, even if there is no life threat, even if we find a 3-year-old wandering down the sidewalk, we're not just gonna be like, oh, he's probably just walking the playground. He's fine, he's not hurt. It would be involuntary consent. We would take them to the hospital, get, social services involved to try to find who the kid belongs to, type thing. So again, guys, we'll jump into this a little bit later. But if we have a patient who is going to fall under that involuntary consent category, and they are not going to want to go, they're going to fight you tooth and nail. If we can't talk to them and reason with them, we can move to the point of forcibly restraining them, physically tying them to the stretcher in order to make them, able to be able to transport. This is a last resort. This should never be your first thing. Haha, yeah, argue with me. I can't wait to tie you down. Never, never, never. All right, it will never go well. Okay. If we are getting to the point of tying somebody down, physically tying somebody down, what are some things we need to keep in mind? They're going to resist violently, right? I grew up with 4 brothers. Anytime we would wrestle around and they would pin down my arms and legs, guys, I went from 0 to 6 real quick. That really irritated me when I couldn't do anything to push them off, right? If they're already irritated and they're not being cooperative because they don't want to be transported, and you physically tie them down to a stretcher, what do you think is going to happen to their hostility level? They're going to go Hulk smash mode, right? They are going to have adrenaline coursing through their veins. They're going to have that superhuman strength, and they're going to fight you, and it's not going to go well. All right? So if we're getting to the point where we're thinking we need to physically restrain somebody, what do we need to have in the back of our minds, maybe already getting these things in the works? Okay, so call your supervisor, let them know what's coming or what's going on. Who do we need? Let's get PD there, right? Because what do they have that I don't? Okay, lots of, all right, they have handcuffs, all right? All we have for forcible restraints are some cloth ties. If a patient's on drugs or really, really mad and like a big person, they can break through those ties. All right, so they have handcuffs, they have weapons. If it gets to that point, who else do you think I need to say, hey, can you send so-and-so my way?
You need advanced.
ALS. Why? Because guys, if you're getting to the point where you're physically tying somebody down, what do they need?
Sedation.
They need that night-night juice, right? That's what we call it. Some vitamin H is also what we call it, the Haldol. Because they're not going to stop fighting you once you tie them down. It's going to piss them off even more, and they're going to try everything they can to get off of that stretcher. Go ahead and have PD and ALS en route to your scene before you even attempt to tie these patients down. Yes. I mean, ideally, yes. Guys, all of this I'm saying in an ideal world. If PD is readily available and if ALS is readily available. All right, sometimes you got to do what you got to do, but you need to have a plan. You need to have chemical sedation. You need to have backup in case anything goes sideways with protection. All right, don't just try to like gung-ho and be like, hey, you think we got this guy? Let's go try to tie him down and just wing it. It's not smart, okay? So we're gonna watch this video. This is a really good illustration of having to forcibly restrain a patient, but also understanding the actual etiology as to why they're being combative. All right, notice that these medics are not fighting. They're not yelling back at this patient. It doesn't change the situation. This patient does need to be restrained, but the way they talk you through it, it's a good visual.
COVID-19 is going to affect every aspect of our daily lives, but we shouldn't let it.
It's kind of hard to usually.
Professor A, can you hear me?
Yeah, y'all probably won't be able to hear it. It'll be on the PowerPoint. It's just really low.
Oh, no, one of our classmates needs to be let back into the meeting. She got dropped out the meeting. Sarah Kate Sands.
Got it.
We're solving it straight up. 1, 2,
mean, it happens all the time. So you guys can go through and watch the video. The volume is really low. I couldn't change it, but they're going through the reasons. Okay, y'all see that big old knot, that big old goose egg on his head? So he could have a brain injury that's causing him to act like that. His heart rate was extremely high, 170. That's not normal. It could have been drugs. All right, so again, they're not like having the mentality, hey, screw you, you're defying me, so I'm gonna tie you down. There's a reason he's acting like that. All right, if it is a head injury, sometimes the drugs that we give to sedate them, they're not applicable. Okay, we can make the brain bleed worse if by giving a certain drug. So you notice that they had a plan. They said, hey, let's pick up the stretcher. You hold that leg down. You tie that down. They were asking if he did need drugs, and what was he saying? No, man, no. That's always the answer. Almost always the answer. And you know, saw his response. Okay, you didn't take any drugs? Okay. All right.
So when they act that way and they say that they don't take any drugs, if you were to give them something, you don't know what they have in their system already. So is there a way that you?
So based on our assessment skills, if their vital signs are one way, if their pupils are one way, if they're acting a certain way versus the complete opposite, we can assume kind of the category of drugs that they've taken, and we can give drugs accordingly to kind of that category to try to counteract how they're presenting.
I do have a question.
Yes.
For nurses, I know they need a doctor's order to apply restraints. Do we need a doctor's order, or is it just
nope?
That's it, like the situation you just assessed.
As long as it is in your standing protocols for whatever agency you work with, you don't need to call and ask for permission as long as you're following your protocols.
So how are they like able to video that like patient privacy?
So they go back after the patient like gains consciousness, or they find like, you know, a family member, and they get them to sign consent to say, hey, they video it anyway, but then they get the consent to actually like show it, like after the fact.
So that guy consented to like a live TV, you can see the face.
Yeah, they sign the form. If the face is blurred out, they can still air it, but they're not revealing their identity. So that's why you see the blur. They don't consent to it being on TV. I don't know. Your 15 minutes of fame. I don't know. Yeah. Yeah. More of the reality shows obviously are going to be more realistic. They'll probably play up like the drama of certain things, but I mean, that was a real live call. So yeah, it's not scripted for sure. All right, guys, again, it is so much more work on your end if you restrain a patient. You have to continuously monitor their airway. You have to check their vital signs more often. There's a lot more documentation that goes into it. So you're only, you know, hurting yourself too if you're just doing this for the thrill of it, because you're going to have to do more paperwork and documentation on the other end of it. All right, guys, so we talked about the right to refuse treatments. Again, they have to be within their sound mind. They have to be that A&O times 4. We can't suspect any SI or HI on board, right? Any suicidal or homicidal ideations. No drugs, nothing like that, all right? Now, we will go into, hey, I'm okay with you refusing treatment. You're not dying. You don't really need to go. Versus, whoa, whoa, whoa. You're saying you don't want to go to the hospital, but you actually need to go, okay? So if you have a patient who's alert and oriented times 4, they're in their sound minds, and they're saying, no, dude, I don't want to go to the hospital, I'm fine. They're answering their questions appropriately, they're not drunk, they're not altered in any way, shape, or form, but they're sitting there bleeding out actively. They just got shot, they severed their femoral artery, and they're actively losing blood, and you're like, bro, if you don't go right now, you're gonna die, like for sure. You really need medical help. And they're just like, no, I'm good. It's my time, whatever, you know. Not that they would be like that. But if they're being chill and they're having a true medical emergency based on our assessment, and we're deeming them that, hey, you need to get this seen about, you need to get it treated at the hospital. And they're saying, no, I don't want to go. Don't take me, don't take me. What do I do there?
you have a responsibility to explain to them the risk, right?
Okay, so but I just can't say, dude, I don't care what you say. My medical assessment tells me that you're dying, you're having a life-threatening emergency. It doesn't matter what you say. I'm throwing you in the back of my truck.
Well, no, I didn't see that.
No, I know, but what, can I do that?
They have a right to refuse treatment, so
They
you
still
to
have a
sign
right
a
to
paper.
refuse. If they straight up tell me they're not altered and they tell me they don't want to go, they don't want treatment / transport, and I do it anyway because I think they need it, that's what? Kidnapping.
They're like pass out while you're doing it.
We'll get there. You literally just committed kidnapping if you transport them, even if you think they really need to go, and they just told you in their sound mind they don't want to go. That is kidnapping. That is a lawsuit, literally.
Basically, anything you do in here can be considered a lawsuit.
Hold
This is going to be a fun profession.
Hold on. All right, so insurance thing, what was the question over here? Was there a question over here? No. Okay. So yeah, if it's a, hey, you're having a heart attack, oh, well, I don't have insurance, I can't afford it, I don't want to go. Okay, that's where the laws, it doesn't matter if they have insurance, they will be treated for that life-threatening emergency in the emergency room. They can't deny them that emergency medical treatment. And we can explain that to our patient, okay? But yeah, so let's say, okay, you get called to, it's a summer's day, you're getting called to a neighborhood, and you show up on scene and there's two kind of older men, maybe late 60s, sitting on the front porch playing checkers. All right, and one dude's like, dude, what are you doing here? What's going on? The other guy's his neighbor and be like, hey, I called, you need to check him out. He says his chest hurts. All right, and the patient who has the chest pain be like, no man, I didn't call you guys. It's fine. It's just, it feels like, like heartburn, whatever, blah, 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 it's fine. I talked that patient into getting an assessment done. Okay, you don't have to go to the hospital. Just let me check your vital signs. Let me take a picture of your heart. Let me make sure everything's okay, and we'll just go from there. And they consent to being assessed, right? I do my thing, I'm taking vitals, I put those stickers on his chest, and that monitor tells me he is actively having a heart attack. And I run another test just to make sure it wasn't like a false positive. Sure enough, this dude is having a heart attack. And I say, sir, I'm not trying to alarm you or anything, but you've got some things going on with your heart. I don't like what I'm seeing. I really think you need to go to the hospital to get seen, go get some more treatment, all that stuff. I'm not having a heart attack. My chest doesn't really hurt. Like, it's just, we just ate some chili cheese dogs. It's fine. It's just indigestion. Sir, show them the 12 lead. This right here tells me that you're having a heart attack and we need to get you some help. Okay? No, I'm fine. I'm not having a heart attack. It's fine. I'm fine. I don't need to go. Okay? How do I handle that situation? What do I need to do?
Can't you get APD involved?
So maybe outsmart them, but I have to start going through the steps because that is definitely going to be an against medical advice refusal, an AMA refusal. I have found something that is not good, that is not conducive to being healthy and living, right? It's a bad thing. I think you need to go, but they are straight up refusing, and they have the right to refuse because they're 802.4. How do I go about doing that? What do I need to do on my end?
Document everything.
Document every single thing I say to that patient. What am I going to say to the patient? Encourage them to go get help. How?
Say, like, you're having a heart attack, you were going to go into cardiac arrest, and you were going to die.
Okay, so I had my educational moment first, right? Maybe he was having denial. I showed him that picture of his heart, and I said, this right here is not good. This tells me you're having a heart attack. You're having a heart attack. Like, it's happening right now. All right? They still are like, no, dude, I'm going. I'm good. It's okay.
You explain to him that he might have an extraordinary tolerance for pain, but that pain's going to get worse.
Maybe not. It doesn't matter maybe how you're feeling right now. I'm showing you proof that this is Okay. He still says no. What's my next step?
We get him to sign off on it, maybe get his friend to hold it.
Not yet. Maybe, okay, so try to bring the friend into it. Hey, you called, you need to tell him he needs to go to the hospital. Get the wife involved, get kids involved, get whoever is there. Dude, he's having a heart attack. Tell him he needs to go to the hospital. Okay, so sometimes they can be persuaded by whoever's on scene. All right, what else can I try?
I mean, if you'd like to have seen that before, can you use another example to say, I've seen this advance?
So maybe I can start using maybe some scare tactics, right? I'm not gonna be like, dude, you're gonna die. But hey, this is serious. It is a possibility that if I leave here and you don't go to the hospital, your heart could stop, you could die, all of these bad things could happen. You need to go to the hospital. All right, so we can maybe throw some scare tactics in there, but we have to make sure that this patient understands absolutely everything that can go wrong, up to and including death, if they don't go to the hospital.
So you like need to confirm, do you understand? If
Yes,
you refuse?
absolutely. Because sometimes if they say it out loud, yes, I understand I'm having a heart attack, but I don't want to go to the hospital. Sometimes it comes out and be like, okay, maybe I should go. All right, what is my last step? Okay, so that's technically my last step, but what's my second to last step? Who am I gonna call? Medical control. Guys, you would be amazed. Me as a paramedic, I can say everything to that patient. You are having a heart attack. This is what shows me you're having a heart attack. If you don't go to the hospital, you could die, right? We can send that 12 lead over, that picture of the heart, over to the hospital. We can ask a doctor to look at it, and I can call the doctor. I'm going to call the doctor regardless, right? Because that's going to be part of my documentation for an AMA refusal. But you would be amazed. I can put the doctor on the phone to talk to this patient, and they can say everything I just did verbatim. But because it came from the mouth of a doctor and not a paramedic, it holds more weight. All right, so call med control, tell them what's going on, get that doctor's name. Can you spell that out for me? But sometimes the doctor will, usually in this case, if you call and say, hey, my patient's having a STEMI, they're not wanting to go, can you talk some sense into them? Yeah, put them on the phone. They'll talk to him. Hey, this is Dr. Anschbacher. All right. Oh, I am having a heart attack. Oh, that's the part where it shows that I'm having a heart attack. Oh, I could die if I don't come to the hospital. Yeah, doc, I trust you. Okay, I'll go. Sometimes it works, because that was a real call I had. Okay, dude was straight up having an active heart attack sitting on his porch. He didn't believe me. I tried to scare him senseless. Still didn't believe me. Call the doctor, and he was like, yeah, doctor's probably right. Let's go, Grady. I'm like, but whatever it takes, right? Because even technically, guys, even after I get the doctor to talk to him, he still could have refused, right? He ended up agreeing to be transported, but he still could have refused. He was in a sound mind, right? I'm gonna document the crap out of that call. Because if that patient ends up dying, it better be communicated in my chart. I did everything possible. I will include everything I said to him verbatim. I'll include that I tried to get the neighbor to persuade him to go. I'll include that I called Dr. Jones, and Dr. Jones spoke to the patient, and Dr. Jones urged the patient to be transported, and he still refused. That can happen, but you gotta cross all your T's and dot all your I's. Because if that patient refuses, if they end up dying, they're gonna come through and read your chart with a fine-tooth comb. If you omit any of that information, that how you really, really tried to get them to go, you're liable for that person's death. So anytime it's an AMA refusal against medical advice, you have to call the medical director. They can talk to the patient if they want to. You got to get the doctor's number, but you have to chart that you contacted medical direction, and they either agree to transport or they ended up signing a refusal. If you really think they should go and they're still refusing, you gotta contact med control. Okay. All right, so I had that call, and then I avoided a lawsuit from something similar to that. Showed up for difficulty breathing, big dude, was in his living room. He was sitting like this, he couldn't breathe. He had a condition we call congestive heart failure, which means his heart wasn't pumping correctly. and he was getting fluid in his lungs. He had ran out of his medication that normally helps get that fluid out, and he said, no, I don't want to go to the hospital. I don't want any more medical bills. I've got an appointment with my doctor tomorrow morning. I'll be fine. I'll get my meds refilled. I'll be good. I'll sleep with my machine on tonight. It'll help me breathe. It's fine. I don't want to go. Roommate was in there. I got the roommate to try to convince this dude to go. We called the doctor at Grady, tried to convince him to tell him to go. And he still was adamant. Guys, I did everything within my power. Charted as an AMA refusal. The next morning, there was a call that went out to that same address for cardiac arrest due to die in the middle of the night. Guess whose chart they went through? Mine. They said, oh, look here. We had a call at this address 12 hours ago. What happened with this call? Why didn't they go? All right, because I documented the crap out of that chart because I knew it wasn't going to end well for that guy and he was just not going to go, I avoided a lawsuit. I did everything within my power. I wasn't charged with any type of like negligent homicide or something. Okay, so make sure, especially if it's an AMA, you're documenting everything thoroughly.
So you just like write down literally every single thing that happens in the day.
Oh yeah, everything. You know, patient was informed, or, you know, I told the patient X can happen, you know, you really should do this. I got the roommate's name. I put that in the chart. I documented the doctor that I talked to. All right, so make sure you guys are documenting thoroughly, especially when it comes to AMA refusals. All right, so let's talk about, everybody good? We need a break. Anybody keep going? Okay, 5-minute break?
Yeah, 5 minutes.
Okay. Well, I'll get to you when we get back. 5-minute break, guys. So yeah, guys, during the break, somebody asked a question, what happens if that guy who had his femoral artery lacerated and was bleeding out and was saying, nope, don't want to go, I'm good. Or my guy who was having a heart attack, no, I don't want to go, I don't want to go, don't take me to the hospital. What happens when they pass out because they lose too much blood or their heart's not getting enough oxygen? They go under that implied consent category. Yes, they were just saying they don't want to be transported, but now they're unconscious, unresponsive. I'm acting in good faith of that patient by treating and transporting them. Okay, so you can follow through with an AMA, or you can just wait around until they pass out and just be like, oh, well, now we can go. But yeah, if they do pass out, it is implied, even though they were just saying they don't go. Okay. All right, guys, the HIPAA Act, super, super important for you guys to remember this. Health Insurance Portability and Accountability Act of 1996. That is HIPAA. Guys, what does HIPAA mean? We know what it stands for, but what does it mean?
It protects the information of the patient between the patient and the doctor.
All right, so it is patient/provider confidentiality, right? I cannot let any information based on any of the conversations I have. If you call me out to a scene and, you know, Bill calls me out there and I'm going to be his paramedic and he tells me all of his medical history and all the medicines that he's taking and all of this private information that is only being divulged between me and him because I'm in a healthcare setting, I cannot give any of that information out to anyone who was not what? Directly involved with his care, right? If he tells me he's got all of these health problems, he takes all of these medicines, he's had a heart attack 10 years ago, whatever it is, and I take him to Grady and I transfer him to the care of Susie, Nurse Susie, I can tell Nurse Susie everything that Bill told me because she is also a patient care provider for Bill, right? But I can't go and just be like, oh, hey, I know, hey, you worked yesterday, right? You didn't work today. Let me tell you about this call. Let me tell you about this dude. All right. If I'm telling all of that information to somebody who is not directly involved with his patient care, I'm violating HIPAA. Okay.
If you don't say their name, but you're just talking about like the call, does it not count?
So there are some kind of shades of gray when it comes to HIPAA. All right. I cannot divulge any information, direct healthcare information, or any information about my patient, who he is, who they are, where they live, what their social security number is, what their medical history is, any of that. I can't identify my patient in any capacity. If I go and I say, ooh, guess what? We ran this guy yesterday, and I just tell him about the crazy 12-lead EKG that he had. She didn't know that I ran Bill. I didn't tell her my name. I didn't tell him where we picked him up. I didn't tell him anything about his identity that could let her know, oh, you picked up Bill again, didn't you? Right? Because guys, we get it. We talk shop, right? We'll talk about really cool calls or crazy injuries or backstories or 12 leads or whatever it is. We talk about that with other people because we have a generalized interest. Hey, guess what happened? But you've got to make sure you are not releasing any information to a coworker, or maybe you're an earshot of like a patient's family member, right? If I'm talking to anybody about the call I ran with Bill, if his family member is standing next to me and can tell, oh wait, that's our street, or I give away an identifying marker like a distinct tattoo or something like that, and anybody can identify who my patient was, I am violating HIPAA. Okay? Yes.
I'm literally just
Oh, the question? Welcome to my life. All right, so guys, you can directly, absolutely no questions asked, violate HIPAA by saying, hey, I ran Bill so-and-so yesterday. This is where we picked him up. Here's his information. Let me tell you about this call. That's absolutely directly violating HIPAA, right? But you can inadvertently do it and not know that you're doing it, right? How might that happen?
Talking about a maximum wage gives too much information.
Okay, so you might not have any ill intent to identify Bill as a patient. But if you give away too much information, especially like addresses or maybe times of day in the general area you picked them up, some people can pick up on that. Okay, how else can you inadvertently violate? But this is huge these days. Social media. Guys, there have been several people who have lost their jobs at Grady because they put a Facebook post up, because they made a Snapchat story, because they put a photo on Instagram. All right, now you might see like the picture of the back of an ambulance, if there's blood everywhere, all the equipment scattered, they post it and be like, yeah, you had a long day, like, look at my life type thing. As long as they post that and they don't give any inkling as to who their patient was, where they picked them up, what even the circumstances were for the call, that's okay. You're not letting anybody know who your patient was, right? But if you're in the back, taking selfies with an unconscious patient or an altered patient, or you're posting, a rant about a patient and we picked them up from here or this or that, and you're giving any type of identifying information, even if you don't know that you are, you're still violating HIPAA, and that is still a major, major legal issue you have on your hands. Okay? Right, remember?
Yes. So I say you told a lawyer, would that technically be illegal, but at the same time?
So that's where sometimes you see like these murder trials. They try to subpoena like the killer's like therapist or something. They have certain things that they can divulge if they believe that somebody's like life is in danger, kind of thing. But other stuff like that, it's patient doctor confidentiality. Yeah, that's where a lot of that stuff is like questionable. But guys, if you violate HIPAA in any way, shape, or form, it's a lawsuit. You're going to lose your license. It's not good. So just be careful how you talk about your calls, how you talk about your patients, who you talk about them to, right? Because if you don't really trust or know this person and you accidentally let something slip, you don't know what they're going to do with that information.
In that situation, if you're talking to a therapist, isn't that HIPAA against you, that they can't divulge information that you're bringing to them?
Yep.
So
you're protected. If you're going to a therapist and you're giving this information, they are held.
Talking about somebody and I give too much information about a a patient that I had. You see what I'm saying? Where it goes like back to back.
Yeah, it's kind of like a little loop. Yeah.
I guess that's kind of.
Yeah, you just can't give identifying factors. You can talk about like the call or whatever, but you can't say like who it was. Okay. It better be written, and if anything comes back, you better have, okay, this is exactly, like, it can't be verbal consent. It can't be, yeah. Okay. Guys, I used to work at a hospital in an ICU. It was downtown Atlanta. We had several celebrities that came through, or celebrity family members that came through the ICU. There were nurses who were up on several floors up who had nothing to do with this patient, but they heard that they were in the ICU. So they accessed the chart system and went in and read that particular person's charts. They got found out, they got fired. State of Georgia revokes their license. Okay, even something as passive as that, right? They're not posting it on Facebook. They're not, you know, making this big announcement, but they were not directly involved in that person's care. They violated HIPAA by accessing their chart and finding out private information. Okay, be very, very, very careful about HIPAA, guys. It's a very slippery slope. Just make sure.
What about in the opposite direction? Like if there's a patient in the back of an ambulance and they're trying to take selfies with, you know, medics in the back of an ambulance. I mean, I can't imagine that doesn't happen. Like, what's the policy on that, where you're trying to perform treatment or you're trying to get them to the hospital and they're trying to say, hey, take a picture with me, or hey, do this other
So
stuff.
this is kind of up to your consent, right? If you're like, yeah, sure, whatever, and you take a picture with them, or if you're like, hey, I don't really want you to like post that, then that becomes, you know, if they post it without your permission, it becomes the opposite. It's not HIPAA because you're not the patient, but it's still like against your will type thing. Okay, guys, you may be legally mandated to report your findings, okay? Even more so, making sure that you're charting and documenting correctly. Your document is a what?
Legal document.
A legal document. If something happens and that person dies, or you know you're involved in some type of legal issue dealing with that call, the chart you made about that call, that goes in as evidence. They can go through that chart. They can call you on the stand to testify. All right, so again, make sure you're documenting thoroughly. You will be guided by a legal team to say, yes, you can talk about this. No, you can't talk about that. We don't expect you guys to just like YouTube how to be a lawyer, right? Grady, again, has a great legal team. They will guide you through the process. They try to avoid y'all going to court, but they tell you what to prepare for, how to prep, all that stuff if you get there. All right, so advanced directives, DNRs, these are legal documents as well. Okay, so advanced directives is when a patient is in their right state of mind, they can make decisions on how they want their healthcare to be handled, right? If you have a patient who's in a right state of mind who says, hey, I'm gonna go to this lawyer, I'm gonna get this kind of notarized, it's gonna be an official document. If my heart stops beating, let me go. Don't pump on my chest. I don't want you to put me on life support. They can make that decision. And if they transcribe it into a legal document, they now have an advanced directive. The most common thing that we're gonna run into is a DNR, a do not resuscitate. Which means if we come on scene and we see that they don't have a pulse, they are technically in cardiac arrest, their heart is not beating, and they can produce, or the family member can produce, this piece of paper or this e-document, I'm not going to try to bring them back. I'm not going to do CPR. If everything is in place with what needs to be here in that legal document, I'm going to follow their wishes and say, okay, I got DNR present. I'm not going to try to get this patient back. Okay. You might see it labeled as an AND, allow natural death, but most commonly you see a DNR, a do not resuscitate.
This is part of the advanced directive. It's not two separate things.
So the DNR, that's going to be the advanced directive in the form of DNR.
Okay.
Right. Now, you can have an advanced directive that's not just a straight up do not resuscitate. they get very picky and choosy. And it's crazy to think about, but they can say, okay, if my heart stops beating, I'm okay with you pumping on my chest, but I'm not okay with you giving me drugs to keep me alive. I'm okay with you giving me drugs to keep me alive, but don't pump on my chest and don't put a tube down my throat. Okay, so you can have, it's called DNI, do not intubate. You can have compression only CPR resuscitation orders. You can have chemical only, which means we only give drugs, we don't pump on the chest. There are a lot of different kind of ways that they can be particular. Okay, but we have to have that document, and it has to have everything in check for us to honor it.
How easy is it to read that document?
It's pretty straightforward. It's, yeah, it's also, I've got some examples up here, but it's pretty straightforward.
Do patients usually get?
Hold on.
Go ahead, sir. If you see someone on the street, how would you know that they have this advanced directive?
So the question was, if you see somebody on the street and they don't have it like on their person, if it is not in front of me, it doesn't exist. All right, they might have it, and I might be totally doing what they do. I might be totally going against their wishes, but I don't have it in front of me. I can't see it. All right, so you might say, well, what if that person, what if that person makes it, and I break a rib when I do compressions, and they wake up and they say, oh my gosh, you should have let me die. I wanted to die, and now I've got injuries. I'm suing you. Am I covered? As long as I can prove I was acting in good faith of that patient, that I didn't know they had DNR. It wasn't on their person. Nobody was there to tell me. I would assume that that person would want me to do everything I could to bring them back. They don't have a leg to stand on for, oh, screw you, you should have let me die, and now I'm suffering type thing. You're not going to be, you're going to be covered.
So like, if you find someone on the street, you know, they say, apparently they have like DNR, are you supposed to like check their wallets or something for that kind of thing? Oh.
Guys, you have to physically have that piece of paper or an acceptable e-document for it to be valid. Hold on, there was a question on here.
Yeah, can patients override advanced directives if they're like alert and oriented?
Yes, we'll get there.
Okay.
So does that mean like every time you come across someone who's unconscious, you need to check their person before?
Guys, I mean, you need to, if they're in cardiac arrest and we find them on the street, we're going to start working that cardiac arrest. Through the process of, you know, getting their clothes off, because that's part of what we do. If we come across it, then we're going to say, okay, wait, this is here. But I'm not going to say, okay, I know you're in cardiac arrest. Hold on really quick. Let me pat you down just to make sure you got something that tells me you don't want me to save your life type thing. Yeah. So again, you're covered. You're acting in good faith of that patient. If you start that care, if we find it, then we can stop. Okay. So yes, guys, there are some loopholes when it comes to DNRs. Let's talk about what makes them valid, and then we'll talk about the loopholes. Okay. So you got to have the patient's name on it. You got to have the patient's signature or the legal guardian, because we do have those power of attorneys or POAs, right? Those are people who are legally appointed to make these people's decisions for them. Sometimes people who have, like, you know, stage 4 cancer or Alzheimer's or something like that, they will have somebody make their medical decisions for them because they know they're about to not be in their sound mind, right? And they will tell the POA what they want to do, what their advanced directives are, and it's up to that POA to follow through with it. The doctor's name and signature has to be on there. And guys, very recently, there's no expiration date in the state of Georgia for a DNR anymore, okay? So again, here are some examples. It will be just kind of laid out. It will be checked, you know, do not resuscitate, or hey, here's some stipulations, like the picky choosy things we were just talking about. It'll have everything straightforward. We have to have that, okay? We can have an e-copy. Like if somebody's got a document saved on their phone, guys, we can't like do Mythbusters and try to say, oh, this is photoshopped or not. If everything is there and everybody on that scene is on the same page, yes, this is what they wanted, don't continue to work it, then that's okay. I'm going to document that very thoroughly, but that's okay. Okay. So what makes them not valid? What about that? Okay. So somebody literally was talking about the DNR tattoo, right? First off, if you're going to have it tattooed, spell it right. Okay, and it's not spelled correctly. This doesn't count. This doesn't count. Yeah, it's pretty clear that if I saw that on a patient that it's clear what they want, but maybe they got that on a dare. Maybe, I don't know. If it's not the legal document, I cannot honor it. This, however, does count. If you have an issued medical jewelry that has, a do not resuscitate order, it will have the patient's information. Like on the flip side, it'll have a specific kind of case number that this jewelry was assigned to them. If that stuff is in place, I can use that as a valid DNR. Okay, but not if it just looks like costume jewelry. It doesn't have a name. It doesn't have any other information on it. I'm not going to use that.
Are those just on the wrist?
Yeah, wrists or necklaces. Okay. So now some loopholes with a DNR. These are very frustrating because clearly if a DNR is in place, that's what the patient wanted, right? If a patient has a DNR and you have immediate family on scene, we're in cardiac arrest, we're working, or we're not working because we have a DNR. If it's an immediate family member, they can say, I don't care what that piece of paper says, save my husband, save my son, save my, sister, brother, whatever it is. Immediate family can override a DNR. Now, if that happens, we're obviously going to get that family member's name. We're going to do everything possible to make sure that they're not just like some neighbor who walked in and said, oh no, that's my mom, let her, either let her die or whatever. If they override that DNR, we need to do our due diligence to make sure that they are an immediate family member and, document accordingly.
You do that knowing time is of the essence.
So again, if we can't sit there and play 20 questions, we are acting in what? Good faith of the patient. It might suck because that might not be what they wanted to be done. But if I'm in a sticky situation where I can't concretely figure that out one way or the other, I'm going to do everything I can to try to save that patient and just know that at the end of the day, I did what was right type thing.
What if we took your previous thing of two buddies playing cards and one's having cardiac arrest, right?
Mhm.
Okay. And then he calls the guy's wife and says, hey, so-and-so's having cardiac arrest. Did you on the phone say, okay? Would you accept that as a do not resuscitate?
Probably not. Because guys, in theory, if the DNR is not in front of me, it doesn't exist. So even if the family members, if they're saying, no, they have a DNR, well, you need to provide it for me. I need to see it. Yes.
Nowadays, they have those medical bracelets with like a flash drive in them. Like
Yes.
stepmom has one.
Yes.
And she has like all of the medical history.
Yep. Yep. So they do have them now that a flash drive is contained.
All this time though.
It is time. So that's, if we're not 100% certain, we're going to work it. We're going to start resuscitating. And then if we see that it is valid, then we'll stop the efforts. Okay, but you got to make sure you're proving you act in good faith of the patient, right? Now, on the other hand, okay, so they can override a DNR. What if somebody has no DNR? It's a very old person. They've got a lot of comorbidities. We know they're probably not going to survive the CPR and working this code on them. Okay, even if they don't have a DNR, you guys can't do this. As a paramedic, I can. All right, if everybody on that scene, all of the family members, the fire department that co-responded with me, my partner, everybody's on the same page, look, we don't have a DNR, but she wouldn't want this. And all the family members can agree, and I can go through certain steps to say, hey, we're gonna do what we can to work it here on scene, but we're gonna do what's called a field termination. All right, I'm okay with calling the doctor saying, hey, here's what's going on. 95-year-old female, stage 4 lung cancer, all, you know, we've done all of these check marks that we have to do with our protocol to do this. Everybody on scene is okay. Family members are okay with stopping resuscitation efforts. I need your approval, doc. Tell me I can stop resuscitation efforts and pretty much call the time of death type thing. That's okay too. But again, you as an EMT cannot do that. That's a paramedic thing.
Who initiates that?
Paramedic.
Does it not remember?
So it can be family members or it can be paramedic, because we can pretty much tell when we get on scene through the drugs we give, the background, all that stuff, if this patient's going to be viable to survive this. And if we don't think it's going to be a good outcome, especially if it's an older patient, we can talk to the family and be like, hey, this is what we're doing to her right now. We're breaking these ribs. You know, we're shoving tubes down her throat. You know, if she survives it, which is very minimal, then it's not likely that she's going to have any type of quality of life. Sometimes we can have an educational moment with them and they'll be like, yeah, okay, we're good with it. Okay, so there are some stipulations when it comes to DNR. We have to have it in front of us. It does not exist if it's not in front of us. Family members can override it, and patients can override their own DNR. Right? So you could have a patient who's got a DNR in place and they're actively in the process of dying. And if we have a DNR, be like, okay, we got a DNR present, they can say, no, I don't care, I need you to stay. Then, okay, that's consent. Then we can resuscitate if they go into cardiac arrest. All right, guys, as frustrating as it is, I've worked a cardiac arrest one time in a nursing home. This patient supposedly was a DNR, but they lost track of the actual DNR. It wasn't in their chart. So this little old lady died just like she wanted to, in her sleep, warm in her bed. Because this nursing home couldn't find her paperwork, I had to break like 7 or 8 ribs, put IVs in her arms, push drugs through her, shove a tube down her throat until they could actually find the paperwork. I don't even think they found the paperwork. They had to call a family member. And I talked to the family member and we did a filter. So you've got to cover your butt. If it's not in front of you, it doesn't exist. As long as you're acting in good faith of the patient, you got to work it until it's proven otherwise. Okay. Everybody ready to see if we have an okay stomach? All right. So we talked about working these cardiac arrests. Guys, there are some patients that we come on scene and we know they are beyond our help. Okay. These things that we're about to talk about and we're about to see happen hours after death, or it's just no way that we're going to be able to piece this stuff back together. So there are some times that you show up on scene and it might come out as a cardiac arrest because it's not, the patient's not breathing, you know, they passed or whatever, they found him not moving. If we get on scene and we see these things, we're not even going to attempt to do CPR. Again, the things that we're going to see happen hours after your heart stops beating, and you are not going to get back any function having all of your vital organs without that blood flow for that long period of time. Okay. So you can presume that somebody might be dead if they're not responsive to a painful stimuli, right? If I come up to you and I just like really push on your chest, or I pinch the muscles right here and you don't flinch, right? You might be dead, right? If you don't have a heartbeat, yeah, probably safe to assume that you're dead. If you are not breathing, you maybe could be dead, maybe not dead yet. You can technically still have a heartbeat and not breathe, right? If you don't have any reflexes to any of that, again, painful stimuli, if your eyes aren't moving, if you don't have a blood pressure, if your body temperature is really cold, if you have profound cyanosis, what is that? Blue. So cyan means blue. If you've got blue color to your skin, like everywhere from head to toe, that's telling me that your blood does not have enough oxygen.
What's the condition called?
Cyanosis. All right, so these things I can say, well, probably this is here. I can assume you're dead, but you might still be workable. I might still do CPR on you, right? Because this could have happened maybe a few minutes ago, and I could try to jumpstart that heart again, and we might get you back. But we have definitive signs of death, okay? This is called dependent lividity. All right, because guys, while we're alive, our heart's pumping. All right, it's beating. What's happening every time it beats?
Pumping through our circulatory system.
Yeah, so it is moving blood all through our arteries, all through all of our vital organs, to every part of my body. That blood's moving because my heart is pumping it and making it move. That's how everything lives, is getting that oxygen, getting that blood, right? When my heart stops beating, it's no longer doing what? Pumping.
Moving.
Right. That blood is not moving. It becomes stagnant. All right. So I like forensic pathology. I think it's really cool in a morbid way. So these kind of pictures right here can tell you the position that these patients were in when they died. Right? So what's going on here? This is the head of the patient. Here's the chest. Here's the abdomen. Here's lower extremities.
Yeah, there's one hand on his chest.
So he had his hand on his chest. How do you think it got that blanched white color?
It's the pressure.
He was lying on his stomach.
Probably fell face down and his hand was here. All right, because again, what's going to pull this blood to this area of the body to make this color present?
Gravity.
Right? So gravity is going to be pulling this blood to where it has this purplish, blackish, bluish color. So we can indicate this guy was lying face down because the gravity pulled it to the front, the anterior part of his body, and the pressure of that hand being there displaced that blood that was pooling. So that's why it's white right there. You can also see the bend of his elbow, where his elbow was bent, that it prevented that blood from pooling up right there. It's kind of cool in a weird way, okay? So what about this person right here? This is the head of the patient, shoulders, the back, buttocks right here. So my best
A
guess,
Gucci tattoo?
huh?
Died in a beach chair.
So maybe a beach chair. My best guess is that this looks like the body of an older patient. Maybe they were lying on their back in bed, and that bed had like an egg crate mattress topper on it. Right? So that pattern kind of tells you and gives you a clue to, well, you know, how did they die? What position were they dead? Or did they die in type thing? Where is that blood settling? Where is gravity pulling that blood that is no longer circulating? All right, so this one's not really like super indicative, but you can definitely see the darker color here. I don't know if they pushed fingers right there to show you that, you know, the blood was pooling there, or maybe there was something that caused that, you know, particular form to be there. I don't know. But this person also died lying on their back because that's where it pooled. Okay. If we see that their heart's not been beating for quite some time, there's no point to try to revive them because we're not going to get anything back. Okay. All right. Decapitation / injury that is not sustainable to life. Guys, what is the motherboard of our body? Brain. Our brain makes everything work. It makes our heart beat. It controls our blood pressure. It tells all of our muscles and all of our organs to do their job. Okay. Now, this particular case, this might have happened 5 minutes ago. This might have happened 30 seconds ago. I can go and pump on that guy's chest because he hadn't been dead for hours. But if my brain is not intact, if it is not connected to the rest of my body, am I going to get any type of activity or life back? No. So guys, if you don't notice, the patient's head is right here. The patient's body is right here. This was an actual call that a medic I know ran at Grady. This is not violating HIPAA. It's out in the world wide web. It got leaked from APD. But yeah, this was I guess fugitive. It was a cop high-speed chase. Dude tried to jump out of his car and jump over an overpass misjudged the distance between the rooftops and sheer chance landed on the fence, and that's what happened. Yeah. There are other pictures. It looks like a Game of Thrones prop, like a movie prop. It's insane. But obviously, guys, if I saw this happen, am I going to go pump on that guy's chest? Am I going to bring that back? No. Okay. Same here. All right. What is this? That's brain matter. Okay. So this was, I believe, the backstory. This wasn't a Grady call. It's just an internet picture. But I think it was an ejection from a car crash. Again, I could have witnessed that happen, but I'm not going to go pump on that guy's chest. I can't bring that back. Right. So if it's anything that's excessive like that, like a decapitation, another one's like a burned beyond recognition, where they're in maybe a structure fire or a car that caught on fire and they are just, everything is black charred. I can't bring that back. I'm not going to attempt to resuscitate that. Okay. This is called rigor mortis. This is another cool forensic thing that happens when we die. A byproduct of cellular death is what? Anybody know? Any of my bio people out there?
Bloating.
So yeah, bloating, but
you kind of broke up, so I didn't hear your question. I'm sorry.
So what's a byproduct of cellular death? So some gases. Yeah. So toxins. All right, a byproduct of cellular death is toxins, acids that accumulate. Okay. So when these cells, when these tissues start to not have that blood flow and they start to die off, they start to release all of these acids and these toxins, and that causes the joints to kind of stiffen up. All right. Again, this happens hours after death. So if you go up to a patient who is lying unresponsive, typically one of the first places that we check for rigor, that's what we call it, is the jaw. If I can freely open and close the jaw without any resistance, then I might work this arrest, right? But if I can't open that jaw because it feels like it's just kind of sealed shut, they've been dead for several hours. I can't bring that back. All right, so again, this can kind of tell you how these patients died. Right, so with this one, this particular woman looks like she was lying on her back and was maybe holding on to something. That's the position that she died in, and because she stayed in that position after her death, that's how her arms were fixated in rigor. Guys, this is intense. It's not something where you can just like push it and it usually gives way. It's like significant force to try to move these extremities once rigor sets in. Okay, they have to put like chemicals in the body to break up all of that acid and those toxins to be able to like move them to get them ready for like a funeral and stuff. It's pretty legit. You'll know if rigor is present. Okay. Decomposition. Okay, sometimes you might have this call. This is a smell you will never forget, trust me. But days, weeks after death, I'm not going to get that back. I'm not going to attempt to resuscitate this. All right, so it is okay for some of these conditions that we find these patients in to say, no, there's nothing I can do. All right, so again, we've got to know, did this happen a couple minutes ago? Can I salvage this patient, or is this patient beyond my help?
Instructor A, in these circumstances when, decapitation, all these that you just described, decomposition, decapitation, are we responsible still for the transporting or the cleanup of the scene, or?
No. So what happens, guys? What happens if I come on scene and I find this? Am I gonna pick this patient up and put him on the stretcher and take him to Grady?
You call the morgue.
No. Okay. Guys, we are an emergency service transport for life-threatening emergencies. We don't transport dead bodies. Okay? So what am I going to do if I'm the first one to arrive on scene and I find this? What's my next step?
Time of death.
So yeah, I got to get somebody else there, right? I'm going to get on phone with supervision and I'm going to say, hey, We have a code that we use for this. We call this an obvious 48. So obvious 48. We say that so in case there's any like bystanders or family members nearby, we're not saying, yeah, we got a definitely dead body here. It's just a little less abrasive. So I'll get on the phone with supervision. Hey, I got an obvious 48. I need you to send PD to my scene, right? Because I'm not going to call the medical examiner or the morgue directly and say, hey, I got a dead body. Can you come pick it up? But I'm going to ensure that PD comes to my scene. They are going to sign, because there is a chart for an obvious 48. They're going to sign that they are taking over temporary custody of the body. And they are going to stay there with the body until the funeral home or the medical examiner arrive, and then they'll deal with that. We're not just going to be like, oh, yeah, there's nothing we can do about that. Sorry. Write up a report for an obvious 48 and say, see you later. You cannot leave a body on scene without somebody else signing your charts stating that they're taking temporary custody.
You cover something like that up.
If it's in the middle of a public park, consider it. So the question was to cover it up. If it's not, typically we don't disturb it because in case it's a crime scene, we don't want to compromise evidence. But that's going to be a judgment call. Yeah, if it's kind of out of the eyes of the public, I'm not going to. But if it's something where, like an elementary school parking lot or something like that, then.
I was thinking of it. I have to walk all the people in the park, right? I walk around a lot of parks, a lot of homeless guys in the park, right?
Depends on the foot traffic. Yes, it's a judgment call.
Is that waxy film?
That's part of the decomposition. Mm-hmm.
So why does EMS get dispatched like in cases like this though? Like, I mean, why even show up?
Because clearly, guys, APD can show up on scene and be like, that dude's dead, right? We don't really need a medical expert to show up on scene and say, yeah, he's gone. What it is it's just covering their grounds to say, hey, if this turns out to be a homicide, it's protocol. We have to have a document, that legal document that Grady came out here and made a chart and said, yes, they confirmed they're the medical experts, not PD, that it was a dead body. There was nothing to be done. And if it becomes a case, then your chart is just part of evidence, just to kind of cover the bases. Because we'll get called on scene. PD will already be on scene, and they will request us to respond to just confirm, pretty much, and have a chart to tie to if this goes to court. Okay. Yes.
Would the EMT level do that, or would that be a fee?
You guys can do this. You can document an obvious 48. You can't do a field termination like we talked about. But yeah, if you show up on scene and we see any of the things that we just talked about here, it's within your scope to say, nope, can't do anything with that. Okay.
Would you use the obvious 48 in case of murder and ways and like decapitation?
Guys, and this, it's good to know, but it doesn't change our protocol, right? If we show up on scene and we have a dead body, it's not up to me to determine if the body gets an autopsy. It's not up to me to determine if the coroner comes and picks him up or the funeral home comes and picks him up. I just need to get PD there, so they're in charge of the body, and I don't abandon a dead body and get in trouble for it, right? But it's good to know that cases that fall under these circumstances of death, they typically will automatically get an autopsy for either research purposes, to rule out foul play, stuff like that. So maybe this is good information to understand that maybe you might want to reconsider covering up the body, because if it's going to have an autopsy, you might can alter some of the results. So any like obvious 48 is going to get an autopsy to figure out what happens. If somebody who, let's say like a 25-year-old male with absolutely no medical history just dies in their sleep, then we got to figure out why, what caused that, right? So if you're previously healthy and you have a sudden death, you're going to get an autopsy. If it's a suicide, if it's a violent death, if it was poisoning, if it was an overdose or suspected overdose, they do these things to confirm the manner of death, to make sure there's not a criminal case. Unfortunately, a lot of like life insurance policies, depend on toxicology results and stuff like that. Any car accidents, if you die while committing a criminal act, it's a medical examiner's case, and anything dealing with kids is a medical, ME is what we call them, medical examiner case. Organ donors, you can notice here in the bottom corner of the Georgia license, it will indicate if you are an organ donor. Do I care about this when I treat my patient? Yes. So no, in the sense that I'm still going to treat my patient the same, right? There was an urban legend that nobody in Atlanta for the longest time was an organ donor, because if Grady came up and they saw that you were an organ donor, they weren't going to save you and they were going to harvest your organs on the black market. You can't make that up. That was the thing. All right, so I don't care if you're an organ donor. I'm still going to try to resuscitate you. I'm still going to treat you the exact same. But if I come across the patient's ID and I notice that they're an organ donor, because guys, I'm not like, that's not my first priority when I'm working a critical patient. I'm not like scouring their belongings to try to find an ID. We can figure out that later, right? But if I come across it, I want to let the ER know that they are an organ donor. Why? Because even if they ultimately die, why is it good information to pass along to the ER?
It's all about time, right?
It's all about time. What does that mean though?
So they can keep the organs alive.
So if they're
Viability.
pronounced dead, if they know they're an organ donor, they might keep them on life support to make sure those organs are they keep on getting that blood circulated, so those organs are eligible to be harvested. I know that's a kind of weird word, but taken out and eligible to donate to somebody else. So it's not going to change my care, but it's a good thing to know for the hospital, so they can deem their organs eligible for donation. Okay? Because after they sit for X amount of time, the tissue, the organs start dying, and they can't donate them.
You know how long they would keep you alive? Like make sure your organs
I've seen they've kept the patient in the ICU for like a week, up to a week, before they can get the appropriate resources to get them taken out of the patient and transported and stored and all that stuff. So again, medical identification, we talked about, the DNR tattoo, not a thing, right? But you can have jewelry that says not just do not resuscitate, hey, I'm a type 2 diabetic, or hey, I have epilepsy. All right, that's one of your puzzle pieces that you're going to look for in an unconscious, unresponsive patient, is this medical jewelry. Are there any clues that could tell me why this patient's not responding to? Okay. So here are some examples. All right, here's the medical jewelry. What about this? I can't accept that for a DNR, right? But is this a DNR?
Nope.
As my uncle had almost this exact same tattoo. He was a horrible diabetic, never kept in touch with his sugar. So he would pass out constantly. He got a tattoo on his forearm that said he was a type 2 diabetic. So the first thing that the EMTs and the paramedics, when they saw that, they're like, oh, let's check his sugar. Let's give him some, D50, whatever it is. I can honor that, because it's not telling me not to save them. It's just giving me a clue, right? This says pacemaker. So it's pretty obvious when they have a pacemaker on their chest. But again, I can look for tattoos that are clues as to why my patient's not responding. Okay, that's totally acceptable. Guys, we're gonna go over these definitions and then we are gonna end. It is 5 o'clock. So once I finish out this chapter, if you need to go, absolutely go. You can get off of Zoom, you can leave. I'm still gonna have to lecture and record because we still have one chapter we didn't get to today. So I will still record it if you guys wanna stay, totally fine by me. But after this chapter wraps up, you guys are good to go just because of the time. Okay, so just heads up.
But then we gotta pick up that chapter later, right?
Correct. All right, so just guys, these are definitions you need to know. We've already talked about protocols. We've already talked about those standing or those offline orders. Those are things that are already set in stone, right? You don't have to ask permission to do those things, all right? Negligence. Be careful that you don't carry out negligence. What does this mean? How can you commit negligence?
Not giving the proper care.
By By not following, omitting certain steps.
Not following the appropriate protocol. Wow. What did somebody else say over here?
I just echoed the sentiment. Yeah.
Okay, so just echoed. But yeah, so guys, there's several different ways that you can be charged with criminal negligence. All right, if you know, based on your medical knowledge and your assessment and what was going on with that patient, you should have given a particular medication and you just didn't. Not because it wasn't available or because you dropped it and it broke or whatever. You just chose not to give it because maybe you didn't like that person. That's negligence. If something bad happens to that patient because you didn't do what you were supposed to, because you chose not to do that, that's a criminal offense.
So, like if you're like at a bar on your day off, and you're drinking, and someone just.
No, because you're not on the clock. So the question was, if you're at a bar and you're drinking on your day off and somebody passes out, you are not obligated to care for that person.
Yeah, if you did jump in and try to do something like that,
All because you're
So you have to be careful because if it's your day off, you're not on the clock, you have a couple drinks and you go in and you stumble and you do something wrong with your interventions, then you're going to be held liable for those injuries. But on your off day, if you're not on duty, if you're not on the clock, you are not held responsible to help in situations like that.
So is negligence what if you don't know that see what I'm saying? If you don't do it knowingly, right? You gave one
As long
example.
as you can prove that you were acting in good faith of the patient, you're covered. So a couple examples, guys. You can't control where you get dispatched. You can't control what call you get. Let's say you come on scene and the call is for difficulty breathing. Somebody's having a really, really bad asthma attack. Their airway's closing up. You get on scene and you're like, oh, shiznit, that's my ex-boyfriend. I hate that guy. He ghosted me. He cheated on me. Whatever. F that dude. I'm not helping him.
Yeah, that's
You are on the clock. You are on the job. You arrive on that scene and that patient is assigned to you. That is your patient. I don't care what your reasoning is. If you choose to withhold care from that patient that you should have provided, you are going to be charged with negligence. Doesn't matter who it is. It doesn't matter if it's the governor of Georgia or the president of the United States and you don't agree with their political views. If you show up on scene and you need to treat them and you choose not to because you don't like the way they run your state or your country, guess what? Get a lawsuit. Okay. Also, if you choose to withhold treatments on somebody based on any of their medical background, okay, may or may not have somebody's name on it, had a patient who was HIV positive. They were extremely dehydrated. They needed an IV, they needed fluid, they needed a couple more medications. And this particular caregiver chose not to give them these medications because they did not want to start an IV because they were scared that they didn't want any unnecessary exposure to possibly having cross-contamination with that patient's blood because they were HIV positive. Negligence. That's a criminal lawsuit. That's a civil lawsuit. That's you losing your license and never being able to practice medicine again. Okay, so guys, do the right thing. I don't care if you've got different political views. I don't care if it's somebody you can't stand. You are taking an oath as a healthcare provider to do the right thing and provide medical care to these patients. Okay, if you choose not to, then you're going to be charged with negligence. Standards of care, guys, treat everybody the same. Again, if they have different political views, if they have a different lifestyle choice, if they just have a different philosophy or prerogative, I don't care. You're not going to be a jerk to them just because you don't agree with them. You're going to be nice and compassionate to everybody. You are not going to hold any of your standards higher. You're not going to be judgmental to these patients because they might have a different belief system than you, because their skin might be a different color than you, because they might choose to live a different lifestyle that you think is appropriate or approve of. None of that matters. You treat all of your patients the same, with respect, with compassion, and not with any kind of judgment. Okay, anything outside of that parameters is not okay by my book. And you can get into a lawsuit if you can have any type of proof that you weren't acting in good faith of the patient. If you're being a teetotal jerk, a good lawyer can spin that to say, oh, well, you were saying these things and you were having this body language towards my patient. You wanted them to die, right? So just treat all your patients with respect and with kindness. Duty to act, okay, so we're kind of already touched on that. You are required to provide patient care if you are on the clock, on the job, and you are dispatched to that call and you make contact with that patient. I don't care who it is. I don't care what the circumstances are. That's your patient. You can't arrive on scene and be like, nope, that's my ex. F you. See you later. Hey, dispatch, get in there another unit out here because I can't care for this patient. It's not how that works. All right. You only have this duty to act when you are on duty, when you are clocked in. If you're driving to work and you pass an accident, you're not required by law to stop and help. If you're driving home from work and you pass an accident, or you go to Publix when you're off the clock to pick up some groceries and somebody goes into cardiac arrest, you still might be in uniform, but if you're not on the clock, you can say, yeah, sorry guys, I gotta go. Sorry, good luck.
If you're on the clock and you just like driving your ambulance, say back on a call and you pass a car accident,
Then yes. Yeah. If you're still on the clock, if you're still on duty, you're required to either stop and help the patient, or if you already have a patient loaded, you're required to get on the radio with dispatch to say, hey, we're headed to Grady, but just be advised, send somebody to this location type thing.
Say?
Yes.
I know you're not supposed, like, you can't say I don't want to work on this person because I don't like them, but if it's your family member, like if it's your grandmother or your mother, do they do anything to try and keep you from working on them, or can you work on family and acquaintances and all that?
So, I mean, technically you can. If you unknowingly show up and it is a loved one or a family member or something like that, then yeah, your partner probably needs to get on the radio and say, hey, we've got some circumstances going on here. I need another unit out here because we're one patient care provider down, because that's not really, nobody's really expected to do that. You know what I mean?
But like, you're allowed to help out and be a part of it until more people come, or do they make you leave?
No, they don't make you leave as long as you're doing your job and you're not like, you know, having an emotional come apart, then yeah, you can work it. But they'll usually get somebody else on scene just because of the emotional aspect that comes with it.
Yeah.
Okay. Again, once you begin treatment, you got to carry on. You got to carry out through the end of that duration until you transport that patient to another healthcare provider, or if they try to initiate a refusal. You can't just in the middle of caring for a patient or transporting a patient be like, you know what, dude, you know, I can't stand that shirt you're wearing, or I can't stand whatever. Just get out of my truck. I can't care for you anymore. What is that?
Abandonment.
So that's abandonment. You abandoned your patient that you initiated patient care with, right? And it's also neglect, right? You should have cared for that patient and you chose not to. So you got multiple lawsuits on your hand. All right, we talked about that. Abandonment, again, if the patient says, I want to go to the hospital, I don't care if they're covered in feces and urine and vomit and all types of bodily fluids. You can't say, man, dude, I really don't want to deal with picking you up and putting you in the back of my truck. Just, no, stay here, we'll call you somebody else. Okay, once you initiate that patient care, you cannot terminate that patient care unless your scene safety is compromised or the patient initiates that refusal. Okay. At the scene is a big one, like we just talked about. Guys, this is a huge one that people don't even realize can happen. How can we commit abandonment in the emergency room once we take a patient to the hospital?
Leave them there.
We have got to make sure we have that continuity of patient care, meaning I can't just roll in the patient to the waiting room and be like, yeah, you're fine. You're not going to die. Just go sit in the waiting room. They'll get to you eventually. And then just leave and go back and serve it. I have to make sure I pass that patient care off to somebody else. a doctor, a nurse, a paramedic. I have to give a patient report and say, hey, this is so-and-so. 65-year-old female complains of left foot pain times 1 week. No, obvious deformities, blah, blah, blah. Vitals are stable. Here you go. That patient is now your responsibility. You've got to get that signature on that computer, because once they sign, they're saying what? This patient's my responsibility. If anything negative that happens with that patient after you sign off with that patient care report, it is on that nurse. It's not on you. All right, but if you just dump them off in the waiting room and be like, yeah, I gotta go, see you later, bye. I don't wanna wait 10 minutes to try to track a nurse down and get that signature. You leave, you don't get the signature, that patient goes postal or whatever, and either beats somebody up in the waiting room or runs out of the waiting room because they're unattended and they get hit by a car and they die. Guess whose fault that is? Yours. Because you were technically still responsible for that patient because you didn't get that nurse's signature and you didn't give that patient care report. All right, so just make sure you're not committing abandonment at the emergency room, because this happens a lot more than it does on scene. Patient or paramedics or EMTs, they don't want to wait in that long triage line because they know that this patient's fine, they're stable, they'll go to the waiting room anyway. They really need to pee or they really want to go eat lunch, and they're just like, screw it. There's no need to give a patient care report for this. Not okay. All right. Assault and battery. Again, we can commit this if we don't get what? Consent. Right? Even if I come up to a patient, hey man, what's going on? I'm Kayla, I'm from Grady. How can I help you today? Oh, I'm fine, don't touch me. Well, I really need to get some vital signs on you. I need to do this. No, I'm fine, don't touch me. Even if I simply go and reach and grab an arm just to get a blood pressure, I don't haul off and punch her in the face. I've just committed battery. I've placed my hands on a patient when they did not want me to. They technically can get a lawyer and charge me with battery. What about assault? If I threaten them, if I say, dude, if you don't do what I'm going to tell you to, if you don't get in the stretcher right now, I'm going to put the biggest needle I got in your arm. I might not actually do it, but if they went to a lawyer and said, oh my gosh, they put, like, my life was in danger. I felt afraid. They were threatening harm against me, and they put me on the stretcher and I didn't even want to go. Assault and battery. I threatened them with violence and I put my hands on them when they didn't want it. Consent is very, very important. Make sure you have it before you treat.
So going back a little bit, so say you're like at the ER with like a not emergency patient and they've been cooperative with you the whole time and then you're like in that long triage line and they're like, let me out right now.
Yeah, so guys, we've had instances with that. So as long as you are documenting, you're doing your due diligence. If the patient runs away, because we're not going to like run after him 3 blocks, okay? So we would document, patient became uncooperative, patient became, irritated, patient left in this manner, unable to obtain signature from patient because they left the scene type thing. You might have heard about another one where a crew was transporting a patient, I believe it was a psychiatric patient, down 75, bringing them to Grady. The patient wasn't properly secured in the back of the truck and the patient jumped out of the truck. And 75, they were struck and killed, the patient was. So yeah, guys, we got to do our due diligence to make sure that we're doing everything to make sure the patient does get treatment. If they are insisting, let me go, I don't want to be here anymore, you're kidnapping me at this point, whatever it is, we can find a safe place, pull over, not in the middle of 75, get off on an exit, get supervision on the phone, say, hey, this is what's going on. They're insisting that we let them out, and we let them out in a safe place. That's fine if the patient is initiating that refusal. But if they're not, we can't just like give them the boot or just kick them out.
How did they jump out if someone came back?
They were not secured in the proper area. So all they had to do was click one seatbelt and then dart.
Jose, in that situation, In that situation where the person got themselves out of the back of the ambulance, would you actually be able to pull over and let them out if they requested that, or are they detained because they would not be able to choose that for themselves? Or does it depend?
So if they're under custody, like if they're physically in police custody, then it's not their choice. But if it gets to the point where they're becoming aggressive and they're compromising their safety or your safety, then yes, the quickest, easiest, safest way, like we would pull over, then we have to, again, scene safety is first and foremost, but we have to try to do our due diligence to make sure it's not in an area where the patient's going to be harmed.
Okay.
So it's just kind of a judgment call. Like if you feel extremely threatened, all right, screw you, dude. Get out of the truck. You don't want to be here. But if it's something that you can control and, you know, kind of de-escalate, then yeah, let's pull over. Let's make sure they don't get hit by a car type thing. So again, guys, kidnapping, false imprisonment, if they do not give you consent to transport and they're ANO x4, you can't transport them. We either got to go the route of a refusal, like a run-of-the-mill refusal, or an AMA refusal. We cannot transport if they are adamantly saying, don't take me, I don't want to go. That literally is kidnapping, criminal offense. Thank you. Defamation, all right, there's two kind of routes you can go with this. This is degrading somebody's character. All right, maybe telling fabrications about patients' presentation or beliefs or something, just their character. You're running them through the wash, right? You can be charged with libel, which is written. Okay, how can you be charged with libel defamation? Okay, so it's written in your reports. Guys, your report is always what? It's a legal document. It's what? It's non-biased. You never, ever, ever put any type of opinions in your report. It is always objective and it is always factual. You can never put any kind of insinuations, any type of judgments, or any type of opinion in your chart, or it will be thrown out, and your credibility of a valid patient care provider is out the window. All right, so you can be charged with that if you put opinions in your chart and you leak that chart. Like say if it's like a politician, you pick up a politician and you're charting or you're documenting stuff that they're saying like off the record kind of thing about something that might counteract like their big campaign or they're saying or doing the complete opposite. If you publish that, A, you're breaking HIPAA, and B, you can be charged with libel defamation because you're breaking down the character of somebody in written form. All right, you can also be charged with slander. This is spoken, so slander is S, spoken is S. All right, if you're just talking trash, or if you call up WSB-TV and you give an interview and you're talking trash about this patient, or you know whatever the circumstances are, A, you're violating HIPAA, and B, you're committing slander defamation. So just be careful, be factual. Don't talk to news crews ever, ever, ever talk to news crews. But yeah, just be careful about the way that you communicate your interaction with your patients.
Professor, I have a question before you go forward, because you just triggered a question. So let's just say it's a situation where you are involved with a call and it ends up turning into a situation where the news does show up on site. Who do we direct them to the leading officer or something like that?
So if it's something like that, typically we'll have like higher up administrative people at Grady respond to that scene, like the liaison officer, the public information officer. But if they're not there at that point, if they're trying to talk to you, you'll just look at the camera and just say no comment.
Okay, I just wanted to make sure because I know they usually have a hierarchy of somebody that's on the site. If for whatever reason they get wind that somebody's on site.
A press briefing about anything.
Okay.
We talked about Good Samaritan Acts. You guys are covered as long as you're not trained. Once you are trained, if you choose to act either off duty or during your employment, you got to do it correctly. You got to act in good faith of the patient, or if you're doing it incorrectly, or you know, it can be proven that you are doing it in ill intent. then you're not covered. You're eligible for lawsuits. I'll talk about that in documentation chart or chapter. Mandatory reporting. All right, so guys, while you're on duty as a first responder, as a healthcare provider, if we come across some of these things, we are legally bound to report it to the appropriate authorities. Okay, so abuse of children, abuse of elderly patients, or abuse of an adult patient who cannot care for themselves. If you have an adult patient who's, let's say, a 40-year-old person who has a developmental disability and they rely directly on somebody else to care for them, if we find any signs of physical abuse or neglect, you have to report that to the appropriate authorities. All right, what does that mean? Who's the appropriate authorities?
Yes.
Okay, so maybe police, maybe child protective services. Who else?
Social workers.
Okay, so social workers. Guys, technically you can report it to your supervisor. Okay, that's up higher in the chain of command. That's an appropriate authority for something like that. You just put the ball in their court as a mandated reporter to go further up the chain and get in contact with PD or get in contact with child protective services.
Is that not like in the report that you fill out, wouldn't that be like a set category? You saw that and then that would initiate actions? Or?
So no, you're going to factually document the injuries that you see and maybe the story that the parent or the caregiver told you. You cannot put in your chart suspected abuse and talk to CPS. That's an opinion. That's not factual.
Are there certain
Outside of that documentation piece, we escalate.
Yes, not included in your documentation. You have to make a phone call. You have to have a conversation with somebody to put the ball in their court to either go further up the chain, or guys, you can pick up the phone and call CPS yourself. It's totally up to you, but you have to start that chain of command when it comes to things like this happening. Hold on. Oh, wait, hold on. Question?
Is there a guideline for signs or signals that are considered abuse?
Yes, we'll get there. We'll talk about that. But just right now, know that you're mandated to report it if you suspect it.
Okay.
So like in Georgia, you have to take the mandated report test?
No, it falls underneath your certification, your licensure as an EMT, as a first responder, as a healthcare provider, because we teach you about it in the class. Okay.
So if we post someone that's overdosing, would then we have to report it to the police or just report it in the documentation?
We will get there. The state of Georgia and APD does not, they treat it as a medical emergency and not as a crime. So unless they cause damage to person or property in the act of injecting or, ingesting, then no, we don't have to get people involved.
So that would be the drug-related injury causing some over there.
Yep. So if somebody got into a car crash and caused a 3-car pileup and I pulled a needle out of their arm, then yes, I will tell PD when they arrive on scene, because they're going to write the traffic report anyway. Hey dude, just letting you know, driver of this vehicle, I got drug paraphernalia. That's mandated reporting. But if it's just a single car collision, just the driver, nobody else was involved, PD doesn't get involved. Childbirth, we have to let the hospital know, right, that a baby was born, so they can contact the county. We can get it started for, social security number, all that stuff. That's fun. You get to record time of birth with that. But we have to alert either supervision if they don't request transport, or the hospital, obviously, when we take mom and baby. Dog bites, animal control needs to know, okay, because they have to follow up their protocol, whether or not there needs to be action taken against that animal or the owner. Communicable diseases, guys, this is a big one. This is current events, right? With grading, we have new protocols. If we have anyone who has been around a confirmed positive COVID case or has tested positive or has signs and symptoms, you know, we have to report these things to the CDC to let them know how to track and look at epicenters of these corona breakouts and look at, you know, just all of the research. Again, your documentation goes into the research aspect of EMS. Anything domestic, that one kind of has a little bit of shades of gray. Guys, if you have an adult patient who is A&O times 4 who makes their own decisions and they have a significant other beat them up, it is up to that patient if they want to press charges. We can't go behind the patient's back, and even if they say no, don't worry about it, it's fine, it won't happen again, whatever they say, we can't call AP and be like, hey, you need to come out here, hey, you need to file charges against this person. If it's a minor, absolutely. If it's an elderly patient, absolutely. But if it's an adult patient, that is when they're sound mind, we cannot force involvement of PD or charges to be pressed if they don't want to pursue them, okay? Any type of sexual assault, we absolutely have to report, again, if the patient consents to it, right? They might say, no, I'm not being transported, I don't want the cops involved. That's that patient's choice. We can't force them to press charges. Any type of obvious 48, right? Scene of a crime, anything like that, AP is going to be involved. We just have to get that chain of command started. Guys, ethics and morality, just make sure you have a good code of conduct, a good moral compass, if you will. That whole integrity, what you do when nobody's looking, right? That whole character thing. So ethics is kind of like the global standard definition of what's right and what's wrong, okay? Morals is kind of your own take on that, all right? What you do, how you act, what you deem right, what you deem wrong, how you conduct yourself type thing. Again, you guys, your chart is a legal document. So if it is part of a crime scene, if it becomes part of a domestic, maybe tie-up court case, they can bring your chart into evidence and they can call you to testify. Now, anyone who knows anything about lawsuits or anything like this, how far removed from the actual incident do these court cases happen? Typically average of 2 years for it to go through the lawyers, to go through all of this pre-trial diversion stuff, whatever it is, to actually end up in court. It can be around the 2-year mark. Does anyone remember in this room or via Zoom what you ate for breakfast exactly 2 years ago to this day? No, you don't. All right, so that is why if you have any suspicion that the case you're working on, that the call you get dispatched to and the call you show up on and you provide patient care for, if that has any chance of going to court, you document the heck out of that call. Every little detail, every piece of information that you saw on your patient, what the patient told you, things that you saw on scene, anything objective and factual, put in that chart, because that's going to be the only thing you have to refer to that day 2 years in the future in court. You can't say, well, I think this happened, or I think this. Oh, no, 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 no. It doesn't think. This is your piece of evidence. This is the only thing that you can refer to. If it is not in this chart, it didn't happen. If it's not documented, it didn't happen. So guys, just make sure you're to a T documenting these calls, if it's an abuse case, if it's a domestic case, if it's any type of crime related, because chances are you can get called into court and that's all you're going to have to remember that day. Okay. So again, guys, if it wasn't documented, it didn't happen. You will be prepped by your company's legal team before you go into this. They'll kind of tell you, they're going to ask you these questions, avoid using these words, because guys, lawyers are smart. they're creative. They try to spin things that you say. They try to put words in your mouth. So they try to prep you. Depositions, this is something that you can go through before it goes to court. I've been through a couple of depositions for some charts or for some cases. And the legal team was trying to take care of it before it went to court, right? So they told me, hey, I'm going to sit in there with you. The patient's representative or the family member's representative is going to be in there. They're going to ask you questions. They can't ask you questions anything outside of your charts. You'll have your chart in there. I'll send you your chart 2 weeks before this happens so you can read over it and be familiar with it. Nothing catches you off guard type thing. So this is just you're sitting in a room. It is a legal meeting. It's recorded, but it's not like court. You're not testifying just yet.
And do those happen when you're witnessing?
Yeah, can be both. All right, so really quickly, we're gonna watch. This is a very famous local turned national news case, happened a couple years ago. The Cooper Harris trial. This was the infamous, the hot car death, where the guy who just around the road, down the road in Smyrna, left his kid in the car by accident. And you know, the kid was in there for all day, 8 hours. I think it was in like August or something. The kid died of hypothermia in the car, and he tried to play it like it was an accident. He forgot, but then this POS actually did it on purpose. But what we're gonna watch is this EMT, I think it's a medic, who worked for Metro, a local service, responded to this call. All right, guys, you don't know what you're gonna get. This could be your first call, your first day on the job. All right, so this is just kind of showing you, they're asking you very specific questions. Well, didn't you chart this? Oh, hey, didn't you make a mistake in your chart? Didn't you have to go back and fix your chart? Isn't this something that you were trained for? How did you make this mistake? They're trying, the defendant's lawyer is trying to remove any credibility that this witness has because, well, hey, if you can make that mistake, who's to say you didn't make any other mistakes type thing, okay? So 24 and 34.
Remember that magical afternoon the whole family spent tweeting and texting?
You met with the state, very just, and we heard Mr. Harris's question, referring to the crime scene, continue to refer to the crime scene. When you're called out, you have no idea you're responding to a crime scene, right? And in fact, where this report, the patient care report, soon after June 18th, 2014, and walk-in suppression. Yes. Is it typical to have multiple call-outs doing that? Yes, they're good with that. Do you always do that? Why did you do it on this day? It did being situation was they were fishing, so I knew that I needed to call the court, so I wanted to make sure I reported this and they could have called. Was to do it all, it was really pressurable, and include all the details that you can remember that were important. Right? It would be fair to say that information that you don't include in the report is intentional. Right? I'll let you decide what to put in the report, what not to put in the report. I would say, sure. But there is a way to make transition to the report. And you're familiar with that process of making a transition. Yes. How do you do that? I think that
board and call to your attention some and obviously an accident. And that was regarding violence. And you had indicated that the child was alert. If it was obviously bad medical terms, alert.
That's incorrect.
But I didn't know how to write that, so that was that something that you had gone over, had experienced before in your training? His field? Yes.
All right, so trying to knock his credibility down.
When I first saw this product, I thought it was kind of crazy. Didn't really understand what the benefits would be, but I think what follow up to the Nina's question. Having reviewed the video, you saw the video of the Highway Patrol car the last week now, it was at the cop, correct? And did that accurately report the things to the And then finally, these reports can sometimes be a little bit complicated. You have a copy of yours, correct? Are there areas that are automatically populated that you have to fill in terms of vital signs and things like that? There was questions that was posed to you about doing an addendum. And I know in your addendum was very, very short. You made a couple of corrections. And specifically, you wanted to talk about vital signs that the tenant, you can dig in this case for areas you didn't have it. You did not. I wanted to ask you about the dedications that are here. You got 16 I know that looking back to the beginning of your review, those correspond with times that are here. Second page. Right. That time there, where you start meditation. What time did you start? That is where that 4:49 and that corresponds with your name. Okay. And there's a second time that there what's that time? What time?
Okay, they are going through his chart, nitpicking, right? You change this time. Well, does this correspond? Is this when you started charting? There's also another part in this video where they start talking to him about how he perceived the dad's reaction. Like they talk about, you know, he was in the back of the cop car. Was he showing any emotion? Was he doing this? Was he doing that? Guys, make sure, you know, none of that has to do with patient care. Right, you are there for patient care purposes only. So you can't say, noted that father of deceased child was not showing any emotion. That's not relevant. That's going to be construed as an opinion. So just make sure you guys factual document, because he had to go back and change times. So that one little fix that he had to contact QA to say, hey, can you send me my chart back so I can fix it? I documented it incorrectly. That one little change cascaded all of these. Well, you know, did you fix this? Have you never come across this in your training? Did you not learn this? Have you not experienced this before? Like they will bring you down to a pulp. So just be aware of that. Questions, comments, concerns? I know it's a lot, guys. I know it's heavy. I know it's just boring stuff right now, but you gotta know this moving on. Okay. All right. So, and recording, look at me go.